So welcome to you all, and thank you for joining us for this trainer-trainer session. My name is Sarah Valks, and together with my colleague Aurélie de Waele, I will chair this session. First, I would like to inform you that this meeting will be recorded, and the recordings will be made available on the website of the Coalition for Vaccination after the meeting. Besides the recordings, you will also find a background document on the website, and this background document will contain all the information from today's training, as well as additional backgrounds and resources on the topic of this meeting for you to use during or in preparation of your next trainings. We will not do individual introductions because that will take up too much time, but we would like to include a participants list in the background document. So please let us know via email in case you object to having your name and country mentioned in this list. On a final note, before we kick off, we have posted a link in the chat to a pre-training survey. And we would very much like to ask you to fill that survey out now, if possible, in case you have not done so already, because it was also sent to you via email. It's important to us that you take this survey before the start of the training. It will only take a minute of your time, even less, and it would be very valuable to us. Since we have a full program, I will immediately proceed with introducing the first speaker, which is Alison Maassen. Alison is the project coordinator of the IMMUNION project, and she will give a short introduction on the IMMUNION project in which this initiative is situated. So please, Alison, go ahead. The floor is yours.
Thank you very much, Sarah, and thank you, everyone. Good afternoon. It's really such a pleasure to be here with you today, and we really appreciate you taking the time to join us for this Training of Trainers workshop. So what we'd like to do, and I think, are the slides up, Sarah?
They're coming up.
Okay, yes, great. So... yes, great. I see them. So wonderful. So exactly. So the project today, IMMUNION, Improving Immunization Cooperation in the European Union. We just want to give you a brief introduction for those of you who aren't familiar with it and what the project is about. And to quickly introduce myself, for those who don't know me, my name is Alison Maassen, and together with my colleagues Alba Godfrey and David Hargett at EuroHealthNet, we are leading coordination. And in case you haven't heard of EuroHealthNet, we are the European Partnership for Health, Equity and Wellbeing. We're a Brussels-based network of public health institutes, ministries of health, research centers, and other actors working to reduce health inequalities and tackle determinants of health. So today's session has been organized by our wonderful colleagues at the University of Antwerp, who are leading IMMUNION's Work Package 5. So next slide, please. So this is just to give, again, a brief overview so you understand the objectives that have led us to working together today. The overall objective of our work is to support EU efforts to improve vaccine uptake by strengthening joint efforts amongst Coalition for Vaccination members, as well as other stakeholders to deliver better vaccine education to health professionals and better information to the general public. So some of the specific objectives under that include improving dissemination of existing and new resources on vaccines, strengthening the Coalition for Vaccination, which I'll explain in a moment, increasing training opportunities, both pre-service and in-service for health and healthcare professionals, which is what brings us to this session today. Enhancing collaboration with the media in order to improve the vaccine information that's received by the general public, and improving overall equity in vaccination by studying drivers of vaccine inequalities in our 4 participating countries, which in this instance are Greece, Italy, Latvia, and Romania. Next slide, please. So one important definition, and I see a lot of familiar names in the audience, so many of you already know this, but what is the Coalition for Vaccination? The coalition brings together European associations of healthcare professionals and relevant student associations in the field. It was first convened by the European Commission in 2019 on the basis of 2018 Council recommendations, European Council recommendations on vaccine preventable diseases. So on this slide, you see the 3 co-chairs of the coalition, which represent nurses, pharmacists, and doctors respectively. And below, you also see an alphabet soup of other acronyms, important acronyms, but many starting with E for Europe or European. So these represent European associations of pediatricians, midwives, dentists, hospital pharmacists, physiotherapists, amongst many others. And the project, the IMMUNION project, aims to help enhance the cooperation amongst these partners within the Coalition for Vaccination, as well as to also achieve some of the other points mentioned in these 2018 Council recommendations on vaccine preventable diseases. Next slide, please. And we can jump to the next already. So here you see we're already halfway through the project. We started in April 2021 and we will end in March 2023. So it's quite a short project, but the intention is really that the project's activities, some of which are outlined in this slide, will continue to be sustained after the project's end via the continued work of the Coalition for Vaccination, which fortunately has no finish, no set deadline that it's working toward. So next slide, please. Since the start of the project, we've put a lot of emphasis on our communication activities, including developing a purpose-built website for the Coalition for Vaccination and setting up and managing social media platforms, a newsletter, leaflets in multiple languages, a video. So hopefully you've found some of those materials already, and that's part of the reason you're here today. And the reason for all of this is that we believe that enhancing the coalition's visibility will help it achieve its wider aims of reaching healthcare professionals across Europe and also improve collaboration with other important actors like WHO Europe. Next slide, please. So another important component of the website is disseminating information, knowledge, and resources about vaccines, as I mentioned before, our first specific objective. So this particular session, as Sarah has already mentioned, is going to be recorded so that other healthcare professionals who were unable to attend today will still be able to benefit from the knowledge shared. Some of the other ways that we're doing this include integration with the SECI platform. So SECI stands for Strengthening Education and Knowledge in Immunization. And it's an effort by the Vienna Vaccine Safety Initiative, which is another one of the coalition's associate members and an IMMUNION partner. So their intention is to develop a one-stop shop for health professionals to receive access to validated vaccine training opportunities and eventually to receive what they'll call SECI credits, which serve as a sort of continuing professional education opportunity, as we know how important that is for many healthcare professionals. So at the moment, this website is still largely under development, the credit system, for example, but they have already begun to upload some really valuable resources to their page. So the website, if you would want to check it out, is simply seci.eu. And of course, you can find it through the coalition website. So another way that we intend to disseminate information and knowledge is via an Ask an Expert page. So the idea of the page is that you can access profiles of experts who come from different countries, who speak different languages, who have different areas of expertise. So maybe around vaccinology or maybe around communication with patients. And the purpose is really twofold, either for healthcare professionals to have access to a trusted source of information who might be able to give them some guidance on how they can apply, how they can answer questions in their own setting or improve communication in their own setting, or also for journalists to be able to find trusted sources of information, either for a quote or for some background information about any reporting they're doing on vaccines. The last thing I want to mention on this page is the Vaccine Communication Toolkit, or Toolbox, which is a product of our colleagues in Work Package 6, who are working on this question of vaccine equity in our 4 partner countries. So our partners in that work package found a number of videos, fact sheets, communication materials, and other documents which can help health professionals and health authorities to raise awareness about the importance of vaccines. So just in the last couple of weeks, they've been organizing national roundtables, bringing together health authorities, healthcare professionals, representatives of healthcare associations, journalists, even third-party education, for example, to bring everyone around the table to talk about vaccines and messaging for vaccines. And these toolboxes have been very helpful for that. So until now, the toolboxes are focused primarily on resources from the 4 partner countries, from Greece, Italy, Latvia, and Romania. But we also have some materials from other European projects, and there's a submission form, which we encourage you to use if you would like to send us additional materials. Next slide, please. So now I want to take us to work package 5, our training work package, which is the heart of today's discussion. And to put it all into context, I'm going to show a slide that I've stolen from colleagues in Antwerp. This represents some of the work that they did as part of the Joint Action on Vaccination, EUJAV. It was the Vaccine Training Barometer. So as you see on the slide, they conducted surveys with health professionals or healthcare professionals in Flanders, Belgium, as well as in Spain. And you can see here very clear figures indicating that quite a few, not all, but quite a few healthcare professionals felt that they lacked confidence to answer questions about vaccines. And nearly all of the healthcare professionals surveyed indicated that they would be willing to follow extra courses to learn more about vaccination and about communicating about vaccines. And so when they joined the IMMUNION project, they proposed to address these findings from EUJAV via 2 types of activities. The first focused on pre-service professionals by targeting trainers of, doing a training of trainers. So that's what we have today. And then the second is on in-service professionals, and it's targeted to reach them at various international events and congresses. Sorry, I hear a bit of static. Okay, thanks. So next slide, and I'm coming to the end. I realize time is flying. So I'm really, again, delighted that we're kicking off our first training of trainers session today, delivered in English and targeted at an audience across Europe. So we had over 100 registrations, so that was really great, and it's great to see so many people in the audience. And we're particularly pleased to have so much participation from trainers in Greece, Latvia, and Romania, as the next phase of this training of trainers exercise will be to deliver 3 country-specific trainings of trainers in those countries. And that will be done in the national language and with a particular emphasis on the most relevant elements for those settings. So that's something that we'll work on very closely with the in-country partners there, and please stay tuned for more information. And as mentioned, the sessions will be recorded and made available online for other trainers, students, and healthcare professionals to access. Next slide. Okay, and then quickly, my last point before moving into today's program is that Work Package 5 also organizes these in-service efforts to reach healthcare professionals. They are vaccine communication sessions at international events. And so the objective being to really enhance advocacy for vaccinology and awareness of vaccines with in-service healthcare providers, with a focus on improving capacity to communicate about vaccines. So the first session was held with the Standing Committee of European Doctors, CPME, in March in Brussels, and that was very well evaluated and well attended. There will be the next event online with the Council of European Dentists later this month, actually just next week. And then the final one will be held in person in Greece at the European Pharmaceutical Students Association Autumn Assembly. So that will be in November. And again, primarily looking at in-service professionals, but also future professionals who have an interest in vaccines. So this is a bit of a background about the project. Now, if we could move to the next slides covering today's program. So I thought I have the introduction on the screen, but I thought perhaps I could hand back to Sarah and to Aurélie to give us a run through of the specific sessions that will be held over the course of this afternoon.
Yes, sure, Alison, thank you. So maybe I can simply jump in with introducing the next speaker, and then we will introduce as we go the next talks. Everyone in the room has had the previous, the full program, so I think that would be also fine. So thank you, Alison, for introducing the IMMUNION project. We are happy to work with you, as always. The next speaker will cover the topic of the role of the healthcare provider in the vaccination process. And for that, I'm happy to introduce to you Brett Craig. Brett is a technical officer in the Vaccine Preventable Diseases and Immunization Program in the WHO Regional Office for Europe, specifically working on vaccine acceptance and demand. He has been primarily coordinating in-country support on COVID-19 vaccine acceptance and demand activities for the region. He has a background in social science research, social and behavior change and communication, and has experience with gathering insights and designing intervention, including trainings, in the area of new vaccine introduction and provider-patient communication in primary healthcare settings. So please, Brett, the floor is yours.
Great. Well, thank you, and good afternoon to everyone. It's really a pleasure to be with all of you and just present a little bit from my experience of the role of healthcare providers in the vaccination process, especially across the European region. Working with WHO, we have been able to hear from a lot of health workers in the region, as well as learn about their perspectives and their experiences working with patients, and also hear from patients themselves and understand what the importance is of that recommendation coming from healthcare providers regarding vaccination. So today I'd just like to give you a bit of an overview of not only what we consider to be the important points of why healthcare providers are so important when it comes to vaccination, but also how this relationship between providers and patients and caregivers can be strengthened through communication in order to increase the acceptance of vaccination among individuals. So if you could go to the next slide, please. Okay. And so healthcare providers, how do they impact this vaccine confidence specifically? How do they help people to be more willing to accept and have confidence in the vaccines? Research has shown actually for quite some time now that health workers are the most trusted advisors and influencers when it comes to vaccination decisions. And of course, I'll always add the caveat that while they are the most trusted source, it doesn't necessarily mean that they are 100% trusted or that everyone trusts them completely all the time, right? But it does mean that of the different sources of information, of the different influences on people's decision to accept vaccination, health workers consistently are ranked as the most trusted source. It's important to also note that it's not just health workers answering questions about vaccination, but actually when they make a strong recommendation for vaccination, this is a strong facilitator for vaccination uptake. And so that is where that communication element starts to come into play. The provider's relationship with individuals, of course, also makes a difference. It's not just the words that are being said about recommending vaccination, but who it's coming from. And when it comes from a health provider who has a positive, trustworthy relationship with their patients and with caregivers, then, of course, the decision to vaccinate comes much more easily. And this is largely because individuals require consistent and accurate information. And there's, of course, lots of misinformation or other negative experiences that sometimes individuals can have that come along that disrupt or take away from individuals' confidence in vaccination. But that consistent messaging and the consistent support and strong recommendation from healthcare providers in a respectful, positive manner, using excellent communication skills, this is where the biggest impact can happen. And so basically, many health workers, even though that they have this potential to be a great influence, don't actually necessarily fully maximize their potential in this area. This can be for many different reasons. If you could click to the next so that the image appears. It's that many underestimate their influence. They don't see or don't understand how much of an influence they can have. Others don't feel they have the time, or maybe it's not part of their role, but others also lack the confidence in their own communication skills and how to address patient concerns or questions or even resistance to vaccination, which is why this is often a missed opportunity for healthcare providers. Okay, but the opposite is also very true, that when a healthcare provider has that confidence, understands their role, and understands the positive influence they can have, then they are a strong driver for acceptance of vaccination. Okay, if we could go on to the next slide, please. Okay. So just a little bit of data coming from COVID-19 research. First, with the behavioral insights surveys that have been conducted across the European region throughout the pandemic and throughout the vaccine rollout, consistently across countries, we saw that the trust in healthcare providers increases people's intention to vaccinate and their likeliness to have already been vaccinated. And so there's a strong correlation there. But we also conducted a lot of qualitative research, hearing from healthcare providers and also from other members of population groups such as older adults. And we also heard not only the same thing, that healthcare providers were most trusted, but also it added a little bit of detail or depth to this understanding. If you could go to the next bullet. The reason that healthcare providers were the most trusted, and which led to vaccination, wasn't just because of their expertise, but that people wanted to hear information about vaccine safety, specifically about tailored recommendations to their individual circumstances or their specific health conditions. This was key because this shows that it's not just any healthcare provider that they want to hear a recommendation from, but it's their healthcare provider, the one who knows their health history, their health status. They want to know that if the vaccine was safe for them individually, that it would be the best decision for them individually. And this is, again, where communication is so important, is how do you tailor that conversation, which I'll talk about in a second. And then unfortunately, also the inverse was also found to be true, that those who have lower levels of trust in healthcare providers were also less likely to have been vaccinated or have less intention to vaccinate as well. Okay, if we could go on to the next. All right, and to the next slide, please. Okay, so if we think about it, just first I'll give you an example of COVID-19 situation, just to put this from the perspective of the patient themselves. And let's say we have an older adult who's contemplating whether they should get vaccinated against COVID-19 or not. Of course, the role of the healthcare professional is very important. As I said, there's a large influence there, but we also know that there are other factors or other influences going on. So I just want to give an illustration of what this looks like. Let's say that this older woman, let's call her Rosa, and Rosa is thinking, should I get the COVID-19 vaccine? Is it safe for me or not? I've heard lots of different things. And so if you could go ahead and add the images here. Yeah, and so family and friends might have said different things about it. Social media or news could allude to safety concerns, etc. Okay, she might see advertisements to get vaccinated, but ultimately she's wondering, is it safe for me because of my age? I don't have great health, or maybe I have diabetes, and I don't know if I've heard that these vaccines have severe side effects, and that could be a severe problem. Okay, and then if she goes to a healthcare professional who then gives her a regular checkup, let's say she meets about her diabetes, let's say with her specialist, whomever it is, and a strong recommendation to vaccinate against COVID-19 is not given, that also sends a message. That also tells Rosa that, well, maybe it's not safe for me, or if it was so important, they probably would have brought it up for me, etc. And so while we know that many people have been hesitant or had questions or concerns, many have not felt that they have been given the right information or had a strong recommendation clearly from a healthcare professional. And that is, again, a missed opportunity to strengthen vaccine confidence. If you could click one more time to show that, in addition, that's the COVID-19 example. If we look as we are now looking to see how has routine immunization, for example, been affected during this time of the pandemic. We know that some countries are starting to report there might have been a decrease or there might have been an effect, and we need to understand that better. But we want to understand from the perspective of caregivers or parents especially, what are these different factors as well, and how does this healthcare provider still play that really essential role in building confidence? Can they answer questions in a respectful manner? Can they understand the concerns of the patients and caregivers who are going to have concerns or questions? In the midst of lots of different messages, lots of different influences, it causes uncertainty or concerns, but the healthcare provider is the one that is most likely to be trusted as the source to resolve these concerns. So you can go to the next slide, please. Okay. And the way that that is done is through effective conversations, individually, in order to tailor and meet the needs of the individual parents, caregivers, or patients. And again, this is important because many have different concerns and are at different stages of what we call the vaccine acceptance continuum. And some are already ready to accept, and that's a very easy conversation to have. Some, a very, very small percentage, are hardcore refusers and they don't want anything to do with vaccines. But actually, what we tend to find is a large percentage are in this middle group called hesitant. And they might lean towards acceptance, but they might also be leaning towards refusing or somewhere in the middle. And each individual is in a different place on this continuum. But the overall goal through effective communication with a healthcare professional such as yourselves is that we want to move them closer to acceptance. Wherever they are on this continuum, we want to help them move closer to accepting vaccination. And that's the role that good communication can really play. Okay, if you could go to the next, please. Okay. Yep, and just one more. Yep. So the key way to do this, and I'll go through this very quickly for the sake of time, but one of the key aspects we have found of communicating effectively about vaccines to parents, caregivers, to patients directly is helping them understand the risks and benefits. If you could click ahead, yep. Not only they tend to have concerns about the risks of the vaccines themselves. And when they hear something concerning, many people tend to focus solely on the risks of vaccines, receiving a vaccine, and tend to amplify or even exaggerate in their mind how common or how expected those risks can be. But in a good conversation with them, what you want to do is focus on balancing the risks of infection, which means the risk of the disease itself and contracting that, especially unvaccinated, all right? But then also balance with that the risks of vaccination, what the actual evidence-based risks are, and then also the benefits of vaccination. If you could just click and get the 3 circles on it, yep. And so this is really how we want to structure conversations to help individuals understand the risks and benefits, because they tend to perceive risks of vaccination often as being very high and not necessarily perceiving the risks of infection as being as high as they actually are, and not understanding the benefits completely of vaccination. So one of the main goals of communicating effectively about vaccines that healthcare providers have is to help individuals have an accurate understanding of the risks and benefits associated with vaccination. Go to the next slide, please. Okay. It's important that they understand the risks associated with contracting these particular diseases, the benefits and risks associated with the vaccines themselves, but that also they know how to find trustworthy information, because we know that vaccinating is the best decision to make. In order for individuals to arrive at that same conclusion, they need to have an accurate perception, an accurate understanding of what the risks and benefits are associated with them individually. And that's why that tailored communication is so important. Click ahead. The general rule is that people who tend to perceive that the risk of a disease is very high are more likely to vaccinate, whereas those who perceive a low level of risk of the disease or a high level of risk of vaccination are less likely to vaccinate. And this is the general rule. It can vary. We saw with COVID-19 actually that there were those who had perceptions of high risk of disease, but also high risk of vaccination, and they were kind of stuck and they didn't know what they should do because they thought the vaccines were much more risky than they actually are. And so working with each individual in order for them to understand that the risks of disease are higher and the risk of vaccination is low, and it makes clear what the choice should be. Next slide, please. Yeah, and so again, this is what sets up this opportunity for health workers to be able to communicate effectively. And just some basic principles that we have found to be very important in communicating about risks and benefits with individuals. So first of all, making sure that you have ready the most current knowledge. Make sure to be able to tailor it to the understanding of the individual that you're talking to. Don't overcomplicate it. Don't provide more than is needed, but keep it simple and direct. Also, what we want to do is to make sure that they know what our opinion is. And I have found that many healthcare providers are good at sharing information, but stop short of making a strong recommendation. They feel like that they don't want to be too pushy. And certainly we don't want to make the individual feel that we are pushing or coercing or forcing something onto them and make them uncomfortable. But at the same time, we don't want to miss the opportunity of helping them to know that we as a professional who is responsible for the care of them or their child, that we want to make clear what our recommendation is, that we want to give it clearly and simply and strongly so that they don't doubt what we think is best. So that is really an important aspect of it as well. And we can do that while still maintaining respect for their decision. Respecting doesn't mean agreeing with, but it does mean that we don't try to belittle or force or push, but instead we make it very clear that we'll continue to support, but that what we think our professional opinion is and why. And then, of course, again, make sure that we openly explain the risks and benefits of the vaccines. We don't try and conceal or hide any information, because especially nowadays, they will have access to a lot of information. They will have heard a lot of information from different places as well. So we want to be very transparent and help them understand what the actual evidence says and what the risks actually are. This whole approach is a very different way from an old traditional way of simply communicating with patients as an authority figure. This is much more of a patient-centered approach, which means that we want the patient or the individual, the caregiver, to make the right decision, but we want to make sure that we are providing the information so that the correct decision, the best decision for their health or the health of their loved ones is clear. And so that is a very patient-centered approach that we want to take. And then lastly, we want to make sure that our messages are clearly understood. We don't want to overcomplicate, but we do want to make them understandable. We want to use evidence, that it's not just our opinion or not just our preference, right? But that it is evidence-based recommendation as a professional. We want to make sure what evidence we are sharing is directly related to their concerns, so that we aren't just throwing facts at them to try and impress them, but actually it shows that we've listened, we've understood, and we are directly addressing their concerns to show that the evidence about their specific concern still shows that vaccination is the best choice. So these are just some of the insights that we have learned working in this region that we will continue to work with, and we strongly are always seeking new ways to support health workers in this area of communicating about vaccination to parents, to caregivers, and to individuals themselves, because we know that it is key for strengthening confidence in vaccination. And so we thank you all for participating in this training, and we wish you all the very, very best. So thank you very much.
Thank you, Brett, for this excellent talk and for offering us your insights on the essential role that healthcare providers play in the vaccination process, which has become increasingly clear during the COVID-19 pandemic. We will have a Q&A at the end of the session, so unless there are any burning questions from the audience, I would like to proceed with introducing the next speaker. In the next part, our colleague Hendrickx will talk to us about the state of vaccine confidence in the EU. Greet has worked as a senior project coordinator at the University of Antwerp within the Center for the Evaluation of Vaccination, the CEV, where we also work. Vaccinfectio since 2007. She is involved in several international projects on vaccine hesitancy, training and communication, such as the EU Joint Action on Vaccination, ECDC projects, IMMUNION and the Vaccine Confidence Project. And she furthermore supports all the activity of the Viral Hepatitis Prevention Board. So thank you, Greet. Please go ahead.
Thank you very much, and good afternoon, everybody. I almost would like the organizer to thank me to invite me to present, but I don't know because I'm one of the organizers, so it's very strange to do it. What I want to tell you this afternoon is a little bit on vaccine confidence in Europe. I would like to acknowledge Emily Karafiliakis and Heidi Larsen, who are the main partners in the Vaccine Confidence Project, where we are currently working together on the Vaccine Confidence Project in Europe. The hub of this project is located in our university. So to go further, I want to go quickly on the vaccine hesitancy, more on the definitions, but also on the global part of vaccine hesitancy. What does it mean in Europe? Is there an impact of COVID, and how volatile the vaccine confidence is on itself, and the impact of misinformation and social media. And then I would like to end with some actions that can encourage the vaccine uptake. It's not always good to only give problems, but we also want to give some small solutions. What is the definition? The definition of vaccine hesitancy is in fact set by WHO during a SAGE meeting, and the vaccine hesitancy is called the delay in acceptance or refusal of a vaccine despite the availability of vaccine services. So this slide was already shown by Brett. It's the vaccine hesitancy is in fact a continuum between the people who accept all vaccines or the one who refuses and refuse the vaccine, and this one we call more in the language that we are speaking as the anti-vaxxers. So people that are hesitancy can be in between these two barriers, in fact. Vaccine hesitancy, it's the determinants of vaccine hesitancy are a huge amount of determinants that you can split, in fact, in three major groups. That's the vaccine and vaccination-specific issues. You have individual of social issues and influencers, like you have the belief of the person itself, the trust that he is putting in healthcare provider, or the experience a person had with previous vaccines. And then you have also contextual influencers, and there we are more thinking on the religion itself, for instance, but also the political system and all, in fact, contextual determinants that can have an influence. So you have a big amount of influence on vaccine hesitancy. Vaccine hesitancy is nothing new. It exists already from the beginning when they started to inoculate the cowpox. You already had some, like here illustrated, people that were hesitant and that were thinking that a lot of very strange things would happen when you get vaccinated. It also, a lot of fear and anxiety has to be taken away in the years that we are vaccinating. And most of this role is taken, in fact, by the healthcare providers that really take away the fear of the people who will get vaccinated. It's not only a European issue, although you may think that when we have this title that we are only looking for European issues, but you can see that it's a global issue. In 2016, Heidi Larsen did a survey among 67 countries, and it gives an overall picture of the hesitancy at that moment in the world. But what is what you can see is that especially in Europe, you have a lot of red colors. It means that you have a higher hesitancy level in Europe. Especially France, it was at that time the most hesitant part of Europe. The same picture you have 2 years later in 2018 when the same study was done, and then you see more the north-south division between in the world, where you have less hesitancy in the southern part and more in the northern part, and then especially again in Europe, again countries like France, Bosnia, Greece, shows more hesitancy than the other countries. This made the WHO including vaccine hesitancy as one of the top 10 global health threats in 2019. So it's also a threat in which they would like to do more efforts and to discuss and to support more activities to avoid these threats, these global health threats. So what is important on vaccine confidence and vaccine hesitancy is that it's not only the vaccine itself that causes the hesitancy, but that you look to the overall picture, that there is an interference between the product itself, the provider, and also the political environment in which this is placed. So it is if the vaccine hesitancy is studied in correlation with the trust in politics and the trust in authorities, there is often a link between both. Also, during the COVID, it was clear that the influence of populism is very important on the hesitancy and the confidence. As you can see here, what they tried to do, or what they did in the research, is to, on the x-axis, you can see that they have the votes for populism parties in the country in comparison with the vaccine hesitancy. And then you see that there is really a linear correlation between these two things. It also explains why countries with very populistic parties in the regime, that they also, how they tackle the COVID pandemic was at that moment that they blame a lot of outsiders, that they were that this was not the country, but that they were causing this pandemic, and they also create denialism, or also they contempt the institutions that are working on to have a solution for the pandemic. So, and now vaccine confidence more, I want to go a little bit more in depth in Europe. So from 2016, it was already very clear that in Europe, that Europe was more hesitant than the rest of the world, and especially in France, where only 40% of the people from France accepted, in fact, vaccines and were thinking that the vaccines were safe. So the majority, they have doubts and are hesitant. And how comes that a lot of people are hesitancy? It's a little bit, it's varying by time, by context, and by the country itself, and also by the rumors or the information that is circulating in the country. So it, for instance, for HPV, we had there were some problems in Denmark and in Ireland, and there were rumors circulating what they called the POTS disease, that was linked to the HPV vaccines, but also in other countries, MMR and autism was linked. So it's depending a little bit on what is circulating as rumors in the country that could have an influence on the hesitancy of the vaccine confidence of the people. We want to give an example of the HPV, where you have in some countries you have an increase in the take-up in the vaccine coverage. These countries are mentioned here, but you also saw in European countries that suddenly, although they started very well, suddenly they had a dip, and for some countries it was really that it almost went to coverage of 30% and even lower. And this could be linked to rumors that were circulating into the countries. And the other countries, they stay more stabilized, or also have this tendency to go to lower coverage due to hesitant people or circulating myths and rumors in the country. So in 2020, the Vaccine Confidence Group and our university did a study on the vaccine confidence in the European countries, including also the UK at that moment. And we can summarize this that with a very positive message that the large majority of the European countries have an high confidence, so they think, or they are convinced that vaccines are important, safe and effective. So it's always important to don't think that there is only vaccine hesitancy. The most of the people, they are also convinced that vaccines are good and that they want to have the vaccines. If we compare it with the survey that was done in 2018, we saw even a better vaccine confidence in 2020. And so there is a substantial improvement of the safety in most of the perceived safety in most of the countries, as you can see here. So overall, more than 92% tend to agree that vaccines are important. That's a top bar that you can see. But although you have some differences with the different vaccines. If you compare the 2020 with the 2018 in the importance of vaccines, if you see to the right-hand side, you see the green ones that are the countries that improved in the importance when the questions are asked of the importance of the vaccines and the safety of the vaccines. More countries are more confident. Only Spain had a decrease in the confidence, but it was not really extensive, the decrease in these countries. So which demographic determinants are important to mention for vaccine confidence in general in Europe? It's that males are found to be more likely than females to accept the vaccines, also people above 65 years. Education has a positive influence, and if parents have more children, also they are more in favor of vaccine. But when studying overall results, never forget that you can have typical groups in the population, that these groups are mostly called pockets, that can have lower confidence. A good example of that is often given migrants, but not only migrants, also for instance in pregnant women. You can see that there is still if you call it a problem, but if there is still less confidence. So our colleagues Kirsten Martens and Larissa de Brabander recently did a study on the vaccine acceptance and the vaccine confidence in pregnant women. And what you can see there is that in general, the confidence of pregnant women for vaccines is much lower than the confidence you have overall in the country. So there is still a lot of work to do on this pregnant women and the vaccine confidence, to create confidence in the vaccines in this pocket group. What also important is to mention is that the vaccine confidence is also volatile. So it means if you do a survey in 2016, 2018, 2020, a lot can happen, and a lot can happen with the vaccine confidence. Here you see the global trend. If you compare 2015, the left part of the graphs and the maps, and the right part is 2080, you already see it immediately that the colors, that the red color is more disappearing. So in 2018, there was already a trend to have less hesitancy than in 2015. Also, if you are doing, for instance, before the COVID and after COVID, this can have an important influence on the vaccine hesitancy. So here also, it seems that their European countries were also hesitant to take, to accept the COVID vaccine, but the difference between the other countries is less pronounced than in the previous survey, meaning that COVID really has an impact on the hesitancy or the confidence in the COVID vaccine itself. So if you ask the people in September 2020, when the expectation for the vaccination was still very high, it seems if you then ask if they would get the vaccine, there were still in the countries that have a low confidence. Also here you see again pop up these countries, and it's like France, Hungary and Poland. Also there, they had less people who would like to accept the vaccine. Don't be afraid, this is a big amount of data here, but it's only to give a flavor on all countries here. We put all countries together of Europe, and there, what is important to see is that confidence or hesitancy can be very different in different countries. So it means that if you compare over from 2016 until 2020, the red line, it's the hesitant, the really hesitant who doesn't want to accept vaccines. The blue line is the one who wanted to or are how you call it, neutral people, and the brown line are the one who are hesitant. So, and you see that if you compare the countries, you see that there is a lot of difference in countries, meaning that it's very difficult to predict how, if you have done a study in one country, you cannot predict what will happen in another country, because the determined factors are really country specific, but also specific on events that are taking place in that country at that moment. So if you then take the willingness to receive the COVID vaccine in Europe, the general vaccine acceptance of COVID, the most important reason why people would not take the vaccine is the safety issues, with a very high difference in all other possibilities. Safety is the important or the perception of safety is important in the willingness on taking the vaccine. And this you also can see in the uptake in the vaccines in 2020. Even in the European countries, there is a big difference among the countries in the acceptance, what you can see over here, and also among the different groups. In Europe, you also have there in the different age categories, you have also differences in uptake of the vaccine. The impact of misinformation, as I already said, vaccine hesitancy is nothing new. It's something that is in history. You saw it already that people are hesitant, but the spread and of the misinformation is different in the area of social media. So if you had, for instance, the impact, if you saw the impact of the rumor of autism and hepatitis B that was it was taking place, I think, in the end of the 90s. You had really in the impact of these rumors on the coverage, you saw really a tremendous impact, and it took a long time to again bring up the coverage in certain European countries. But if this would happen now, it would go much faster than before, because there is an interactive exchange of many users on social media, and so the methods of spreading rumors and myths are completely different with 20 years ago or 30 years ago. So the amount of information that is available increased greatly, but it doesn't mean that the quality increased, because the quality on the information that can be found on the internet is also going down, with a lot of personal opinions and misinformation that is circulating on the social media. As you can see on Twitter, for instance, in 2020, in April 2020, every 45 milliseconds there was a tweet launched on COVID. So, so you can imagine that people are overwhelmed with information on Twitter that are not always correct information, but that people get in. And this you also can see on the graph. If there was a volume, the green part here under the bars, this is the volumes of tweets that were detected on COVID. You see if there is an upcoming of the amount of tweets, that after this the vaccine hesitancy is going down every time. So if they measure the sentiment after this popping up of these tweets, there is an influence on the acceptance of vaccine. Also, this misinformation that is circulating on vaccines, and then the example that we have here is the COVID vaccine. If you can lead to really polarization, so you get groups that are in favor and against, and so the spreading goes very fast, and this polarization is really creating anxiety and fear, and it may lead to that people doesn't want to accept the vaccine anymore. So important is that we not always look at the negative side of vaccine hesitancy. We have in the most European countries a high confidence in vaccines. So, but when vaccine hesitancy is popping up, it is important that we are going for actions and interventions. Therefore, vaccine hesitancy, which occur, it's a global phenomenon, but it's a global phenomenon. But in Europe, we have unfortunately the lowest confidence, but vaccine confidence is very volatile, so one event can happen and you can have a big impact on the hesitancy, and this impact is even catalyzed by the social media. What we think it's important is that we need to monitor vaccine hesitancy regularly, so that we can see where pockets pops up on hesitancy, and concerted efforts are needed to encourage vaccine uptake. And what in our opinion is very important is the role the healthcare provider plays in these efforts that we want to encourage to increase the vaccine uptake. Brett already gave a flavor on how these healthcare providers can have an influence, but Pierre will go into a little bit more details what the role can be of this healthcare provider in the improvement of the vaccine confidence in Europe and all over the world.
Thank you, Greet. We will immediately jump into the next part, which will be given to you by Pierre Van Damme. He will inform us about several important initiatives to improve health and vaccine literacy, specifically focusing on information that is available for healthcare providers. Professor Van Damme is Vice Dean and full professor at the Faculty of Medicine and Health Sciences at the University of Antwerp, meaning here. He is Director of the Center for the Evaluation of Vaccination, the CEV, and former Chair of the Vaccine and Infectious Disease Institute, vaccinfixio, at the University of Antwerp. vaccinfixio is a consortium of 4 research groups within the university and is recognized as a center of excellence that functions as a WHO collaborating center for the WHO European region. The CEV is also the European hub of the Vaccine Confidence Project. Besides clinical studies, Pierre's research interests focus on vaccine confidence and education, and in that regard, Pierre is involved in many national and international vaccine educational assignments for both health students and in-service healthcare providers, and also in multiple international research projects on vaccine confidence and communication. A few examples are the yearly Valentine Symposium, the annual summer School on Vaccinology, lectures for specific target audiences, guest professor in several courses on vaccination across Europe, and the Vaccine Confidence Project. He authored more than 400 peer-reviewed publications. So please, Pierre, go ahead.
Well, thank you, Sarah, and thank you, Gerrit, for the putting the scene, I would say, and all the whole context. And from what I heard from Brett and Gerrit, what I can say is that we expect a lot from the healthcare provider today in Europe, because it's a very demanding job, and they should be well prepared and ready for what is ongoing and for the whole context of vaccination, vaccine, and in particular the evolving situation of vaccine hesitancy. So it's my pleasure to talk a little bit more on the role of the healthcare provider and to build on what was said so far by Brett and by Gerrit. You have seen this slide, and I just want to highlight that if we look at the definition of vaccine hesitancy and the different territoria where we have to look at the context of vaccine hesitancy, healthcare professionals are mentioned at several occasions, as you can see here, in particular within the vaccine and vaccination specific issues, but also if we look at the individual and social group influences, trust in health system or the provider, and of course experience with past vaccination. Now, these data here refer to the period before COVID-19 pandemic, and again, I think the 2019 European Barometer on Europeans' attitude towards vaccination concludes that 80% of the respondents would consult a doctor for information on vaccination, and the doctor is really seen as the most trustful source of information on vaccination. That has been highlighted already by the previous speakers, but I think it's good to repeat that, because just imagine we would turn it the other way around and we have a doctor that is not really well informed about immunization, that has a lot of questions related to immunization, or that himself or herself is hesitant towards immunization. Well, that same doctor will have a tremendous impact on the patient population of his or her practice. So that trust relationship between, on the one hand, the vaccinee, the patient and the doctor is something we really have to take into consideration to well understand what is ongoing in Europe and globally, but on the other hand also to use as a very important tool to raise the immunization coverage and the trust into immunization. Before the availability of, and I think I can move on because the role of the healthcare providers during and after the pandemic is clear, we have said that, but if we look at the situation even before the whole COVID-19, it continues to show that very important trust that is present between, on the one hand, the patient and on the other hand, the doctor. What can be the consequence? Well, this is like a role model. the doctor can really have a very strong impact on what the attitude will be among the vaccinee. We all know that a lot of vaccinees will ask the doctor, what would you do in this situation? Would you be vaccinated? And the answer of the doctor is at that moment tremendously important. We know from the literature that healthcare providers themselves can lack confidence into vaccine, that they can be hesitant towards immunization, whether it is COVID-19, whether it is flu, whether it is hepatitis B in the past, or even human papillomavirus vaccine more recently. Some of them have a certain attitude, and that can have a tremendous impact on their patient population. A more recent study also in Italy shows that the reason among healthcare providers to be hesitant towards COVID-19 vaccine, it has to do with, on the one hand, the safety profile of the vaccine or lack of information on that safety profile, or because they receive little or sometimes conflicting information about that vaccine. And then they have really the difficulty how to bring that across the others, how to answer questions from the patient. And that is, of course, something that is for sure not evident. Within the frame of a number of EU projects, and Alison was already referred to that, the team here in Antwerp, under the leadership of Hendrickx, developed a vaccine training barometer. And the aim of that barometer was really to assess the need for vaccine training among the healthcare provider, also monitor the confidence of the healthcare provider to communicate about immunization, and also collect questions healthcare provider could not answer. Because listening to these questions helps us also to tailor the information that healthcare providers will need. You have seen already part of this slide presented by Alison, and thank you, Alison, to use that in your introduction. But I want to highlight here the third column, or the last column, where it's no longer the results of a pilot survey among healthcare providers in Flanders and Spain, but it shows, in fact, within the Coalition for Vaccination initiative, a survey among more than 3,200 healthcare providers in Europe in June 2021, so in the middle of the COVID-19 situation with the availability of vaccines there. And then you can see that all over Europe, more than 50% of those healthcare providers feel confident to answer questions about vaccines. But that means easily more than 45% is not very confident to answer questions about vaccines. In the last 3 months, they got questions that they could not answer at all, among 53% of them. That's a lot. Of course, the last sentence or the last part is also important. They are all very willing, very eager to learn more about immunization, about vaccines, about vaccination. And if we look at their medical curriculum, they admit that they received insufficient support, insufficient knowledge through their standard education. So it is a very important signal towards Europe, towards us all, to improve that knowledge and to support healthcare providers who are really at the front line of the immunization program and the information sharing with their patients. If we look at the future generation of healthcare providers, and I think this is really prevention, it's really preparedness, is to see how can we already do something for that future generation of healthcare providers, the students, medical students, pharmacy students, nurse students, midwife students. And a survey was also set up among those students through the EU Joint Action for Vaccination. And I will just briefly show you a number of results. But if we look at those results, we see that easily a large number of these students, feel that they have not had enough background information, enough teaching, enough educational material related to vaccinology. And very often in the many European universities, this topic has been treated stepmotherly with only a few hours spread all over the curriculum. And there are, of course, exceptions in a number of countries, in a number of universities, but we definitely need to improve this basic knowledge, because that is an investment for the near future, for the future generation of healthcare providers in Europe. A curriculum has been defined, developed and proposed within these European projects, and I think it's very important that we will pay attention in the near future to include this kind of module, educational module, in the different educational programs from nurses up to pharmacists and doctors. That will help to give them already a basis of knowledge so that they can better explain how safety of a vaccine can be assessed, how a vaccine is made, what are the components of a vaccine, why do we have immunization schedules, why do we target certain population groups for certain vaccines. So this is really very important knowledge to support the immunization programs all over Europe. We have many examples of vaccine education for healthcare providers. They are enumerated in the slides. I will not go further into those details, but I think it's important that we pay some attention now to what is being done in terms of information and material developed by the European Centers for Disease Control and Prevention on the one hand, and by the World Health Organization European region on the other hand. Greet, I think we will have the movies now.
Yep. Social and behavior change. And I'm going to give you a brief overview of some of the materials that we have produced in recent years on promotion of healthcare professionals' vaccine health literacy, and also on their vaccination communication skills. So very briefly, what does ECDC do? It's an EU agency, and the role is aimed at strengthening Europe's defences against infectious diseases. And you can see here there's a good list of core functions. Vaccination is not specifically listed, but it has a huge role in much of the work that we're doing. And you can see at the bottom there issues to do with social and behavioural insights and also health communication. This is where the vaccine work has also got quite a major role there. And we've been very much involved over the course of the pandemic in providing all sorts of advice in different areas of the response. So what I'm going to do now is to present 6 different sources for your consideration and your consumption. 3 of them are a little bit older and 3 of them are current or very, very new. This first one here is called Let's Talk About Protection, and it's from 2016. And it's a very practical advice guidance document for healthcare providers such as yourselves who are involved in immunization services and specifically also involved in vaccination for children. And one of the key things it does here is to talk about effective communication with your patients, which of course in this case includes parents. And if you click on the link at the bottom there, you'll see also a set of infographics and leaflets that you might be able to use. This is a sister document to that one, also published in 2016, and it actually targets public health managers and also communicators, but I think there are elements here that would also be of some interest and relevance to frontline health workers such as yourselves. What it's really looking at here is enhancing people's confidence in vaccination and addressing some of the common issues associated with vaccine hesitancy. And I think what's important here is it looks, of course, at individual influences, what issues that I might find personally relevant for me in terms of deciding whether or not I vaccinate or don't vaccinate. But it also lifts this up and it looks at group influences and contextual influences. And I think it's important to take that perspective on these quite complex, multi-level structural issues. This is also a document from a few years ago about addressing vaccine hesitancy amongst healthcare workers from 2015. What I like about this one is that it's based on qualitative research. So it's really going very in-depth into the issues about the concerns that healthcare workers have on vaccine hesitancy and safety. So what we're really trying here to do is to provide people with more targeted and more effective means of promoting vaccines by healthcare professionals. This is current. This is the EVIP, the European Vaccination Information Portal, and it's been going now for a couple of years. And the purpose of this is to provide accurate, objective, and up-to-date evidence on vaccines and vaccinations in general. And we developed it at ECDC in partnership with the Commission and the European Medicines Agency, so it's got quite a few different types of input in there. But it's very much targeting a lay audience, so anyone can open it up, read it, and understand in quite simple terms what's going on there. And I should add that it's also available in all EU languages. So if you prefer to read it in Flemish or in Spanish or in Italian, whatever it may be, you can find this material in your language. And also, I just do want to draw attention to the 6 different issues across the top: vaccination, vaccination facts, disease fact sheets, trusted sources, COVID-19, and surveillance. These are really interesting, rich things to click on. They've got drop-down menus, all sorts of different things to look at there. So have a visit to that website. We also have a set of Q&As on quite a wide range of topics that people might want to have their answers to do with safety, to do with effectiveness, to do with what vaccines will really do in regards to stopping the pandemic, the progress of vaccination within the EU, and so on, booster vaccines. So lots of elements there that you can also get good information on. And finally, this is something which is going to be published in just a very few weeks, early July. We expect it should be available. So we don't have a link just yet, but this is a training, an e-learning on addressing online vaccination misinformation. And some of the colleagues involved, I understand, in this meeting from the University of Antwerp have also been very much involved in producing this as contractors for ECDC. So a big thanks to them for that incredible work that they've done. It's a 6-module course that will be giving people a pretty good overview of the issues surrounding online vaccination misinformation and how to address it. And there are lots of different issues that are covered, including facilitating development of people's vaccine and health literacy, and also how to pre-bunk and debunk online vaccination misinformation. So these are things that are coming up. It's going to be a really good training. Strongly recommend it. So please note this down. And when you remember in July or beyond, search for ECDC and misinformation, and you'll be led to this course. It's very, very good. Thank you very much for listening, and I would like to wish you all the very best in your vaccination work. Thank you and goodbye.
Hello everyone, I'm Brett Craig. I'm a technical officer with the Vaccine Preventable Diseases and Immunization Program with WHO Regional Office for Europe. And I'm happy to share with you something that we have worked on from the regional office in collaboration with the WHO Collaborating Center for Vaccine Safety in Santiago de Compostela. And this is a platform that was specifically built to address the information needs of health workers and the public during the COVID-19 vaccine rollout. So I'd like to share with you this online resource and all the efforts that went into it, and a big thank you to all those who have been involved in this effort and that continue to be involved in it, as it is a continuation of work to update and provide new information as it becomes available. So let me take you to this website and show you a little bit about it that's available to the public, to anyone to be able to use, and hopefully this is a helpful resource for you. First thing we want to do is go to the website, which is www.covid19infovaccines.com. And here it'll take you to the platform. So this is the COVID-19 Vaccines and Vaccination Explained. It's videos and podcasts for health workers and the public that address common questions about COVID-19 vaccines. And they're organized by category to make it a little bit easier for you to find, but also there are, of course, a search function in order for you to be able to look for specific keywords or other concepts around COVID-19 vaccines and vaccination that you might be looking for. Additionally, as I mentioned, this is something that is updated with new information as soon as it's available. And so if you want to be alerted when new videos and new content is posted, then you're able to hit the subscribe button here and put your email in, and then also be able to receive updates as soon as new content is available. Additionally, as you can see down here, that if you are a health worker, there's a more advanced search to look for specific topics and specific concepts and keywords that will help you refine your search. And so please take advantage of that as well. So again, this website mainly is a host of short explanatory videos about COVID-19 vaccines and vaccination, sort of set up as a Q&A type of platform. And these are some of the featured videos you'll see here when you scroll down. But then if you keep scrolling down, you'll see a table of contents. And these are the bigger categories in which these videos are organized. And as you can see, here's some general questions. You can see a little tag here when new videos are available. But if you click on one of the categories like general questions, you'll get a list and also how long each video is. As you can see, these are very general topics, and the videos you can see are kept relatively short. Most are only 1 to 2 minutes. Some might be a little bit longer, but most tend to be short, and the purpose is to be very clear and simple and direct to provide basic explanations for these very pressing questions that have been coming at health workers since the beginning of the COVID-19 vaccine rollout. As you can see here, the questions address questions about vaccination generally, or about COVID vaccination generally, but also about the specific vaccine products, such as Pfizer and Moderna here, the different vaccine technologies that are used. And so these different videos are geared towards health workers, but also can be used and shared with the public. If you click on a video, you'll see it'll take you to the video itself. And there are other similar videos or topics on here on the right as well. And you can watch the video right here. And if you scroll down, you'll also see that the text for each video is available as well. So let me go back to this list again. General questions, vaccine and infection, vaccine efficacy and duration of protection, down through other topics such as safety, which is a very popular one, as you can see from the number of videos that are in this category. There's 18 videos in this category, but then they go through other topics, and as I mentioned, the specific vaccine products that have been WHO approved, and that way health workers who are looking for answers about the specific vaccine products can also find them here. There are also links to some other series of videos related to vaccination, especially COVID vaccination. So this provides, again, easy access for those looking for more information and more answers as well. Now, if you keep scrolling down, the benefit of this is that while many might be able to look at these videos at home, conveniently, they might not always be able to have the videos on hand or ready for them. And so you can also at any time click this download the PDF and be able to get the text of all of these videos on this website right here in a PDF format. And it is also organized by the same categories, the same organization. And you can click on these links in the PDF and it'll take you right to it. So if we wanted to look at vaccines and infection, for example, 2.1, can people still get COVID-19 after being vaccinated? Click on that, and here is the explanation. There are some tags to see what keywords it's related to, but it's broken down into bullet points. It's meant to be very clear and simple, and written in a way that makes the information accessible, especially the health workers who need the basic information, not only for themselves to build their confidence in the vaccines, but also to be able to share this type of information with patients to be able to answer their questions. So these are the resources, the main resources of this platform. I encourage you to please share this platform with others, to use it yourselves, to make it available. And lastly, what I neglected to mention is that it has been translated into, it's now in 7 languages, including English, in the region, and other resources are still available to be able to take the text and to have it translated into other languages still, whether it's taken off the platform and translated and disseminated, or whether it actually is translated for the website itself. To have that language version is also beneficial. And so we are happy to share this with all, and encourage it to be spread and used as much as possible to strengthen the health literacy of health workers in the region around this topic of COVID vaccination, but even vaccination in general. So thank you very much.
Yes, okay, and we can just try to move on with also showing that not only ECDC and WHO Euro, but also within IMMUNION, some initiatives have been taken. In particular, as we do today, to train the trainers on vaccine confidence and communication. And as mentioned, next week we will also have a similar activity. And in March we had already a meeting and a workshop on create awareness among healthcare providers in a session during international events of healthcare provider organizations. So a lot of international institutions and bodies are paying attention to this crucial topic, and I think that is tremendously important. So in conclusion, what is clear is that healthcare providers before and during a crisis continue to be the most trustful source for information on vaccination. We have to use this kind of privileged relation that patients do have with their healthcare provider to maintain vaccine confidence, but also to invest in their knowledge and in their practices. Because at the same time, we know that healthcare providers are not that very well trained related to the topic of immunization and vaccination. They are eager to learn more, and we have to support them maximally so that this will have a very positive influence on their relation with their patients and vaccinees. Thank you.
Thank you so much, Pierre.
Welcome back, everyone, to the second part of this Train the Trainer session. This part will be about communication about vaccines, and also we will receive some tips and tricks for teaching that might be useful when setting up training based on this Train the Trainer session. In a moment, I would like to give the floor to Phillip Schmid. Dr. Phillip Schmid is a psychologist and postdoctoral researcher working for the Horizon 2020 project JITSUVAX at the University of Erfurt in Germany. He studies the psychology of science denialism and health misinformation and aims to support people's informed decision-making in health, for example, in vaccination decision-making. He applies a persuasion psychology perspective to understand the impact of misinformation in health communication and to develop and evaluate promising interventions. He is the first author of the WHO guidance document on how to respond to vocal vaccine deniers in public and the co-author of the Debunking Handbook 2020 and the COVID-19 Vaccine Communication Handbook. He will talk about how to communicate about vaccines, and he will guide a few communication exercises. Before we start, maybe just a practical remark. As you know, this Train the Trainer session is being recorded and will be available online later on, but the exercises will be cut from the recording. So in that way, you should feel free to participate in the exercises without restraint, because this part will not be made available after the session. Good. I now give the floor to Dr. Phillip Schmid.
Thank you very much. I will just share my screen. And now everyone should be able to see the slide set. Is that correct?
Yes.
Right. Okay. So communication about vaccines. Thank you very much for having me. We just heard from Pierre Van Damme that healthcare workers have a privilege. They are trusted, a very high valuable source for information and very influential in the direct communication when it comes down to issues like vaccination. But often healthcare workers don't really know what to say, when to say what, and how to say it. And all these specific issues are addressed in the 3 guidance documents that I will talk about today. The Debunking Handbook 2020, which focuses on how to correct misinformation also about vaccination after the misinformation was spread in, for example, a social media environment. The COVID-19 Vaccine Communication Handbook, which is actually a collection of many effective communication tools on how to communicate in the vaccination domain. And the beauty of that document is that it is based on a living Wikipedia, so to say, because there are researchers updating that document on a weekly basis, and you can click on specific terms within that document and then be directed to the resource and see what the new data on specific communication aspects is. And the How to Respond to Vocal Vaccine Deniers in Public Communication Handbook from WHO, which focuses on how to respond to the very extreme refusers or vocal vaccine deniers when you are in a public debate. All these resources are also listed in the background document that you can enter after watching this talk. So let's focus first on how to respond to science denialism or vaccine deniers, that is, people who actually spread lies and misinformation. What we can do is, in such a situation, not really convince the denier that vaccination actually works, because in a public discussion, when other people are watching or listening, a vaccine denier will never say, oh yeah, you are right, I was wrong. Vaccines actually work, guys. Go get the vaccine because it actually works. That will not happen, because for a vaccine denier, saying something like that is not just saying a new information, but actually means to give up the entire identity that person was built up over years and years. And this is not happening in a public discussion. But what we can do in public discussions, for example, on social media or in a bar, is we can do debunking and inoculation. We heard that today before, debunking and pre-bunking. That means in a public discussion, we can correct misinformation so that the people who are around us and are listening or watching the debate are actually on the safe side, because they know what is correct and what is incorrect. So what we can do is fact check what a science denier or a vaccine denier says. And we will have a look at how this works in a few minutes. We can also inoculate the public against misinformation or false claims by pre-bunking. That means before the misinformation enters the public discussion, we can warn people that they are target of misinformation, and we can give them the skills on how to deal with misinformation themselves and how to detect it. And we will have a look at that as well in a few minutes. And there is a third approach that is actually coming from the debunking idea, so correcting misinformation, and that is rebuttal. Rebuttal is exposing misinformation as misleading at the very moment it is about to reach a wide audience. That means in public discussions. You can, when you look at it from a psychological approach, use technique rebuttal. That means uncover the misleading rhetorical strategies that a vaccine denier is using. Or you can use topic rebuttal. That means you overwhelm the misinformation with actual facts and good knowledge. Both approaches have a theoretical base in psychological persuasion research, and we will look later which of these techniques actually works and what is recommended. When do we need rebuttal? Well, actually in any public debate that we can think of, for example, on social media. I just take a tweet from some random guy, a young child pumped with massive shot of many vaccines, doesn't feel good and changes, autism, many such cases. If you read a tweet like that, then the question can arise, should I respond, and how can I respond to such a, basically very stupid claim? Well, rebuttal was first described in the WHO guidance document on how to respond to vocal vaccine deniers. And later we ran some empirical evaluations on whether that actually works. That is published in the Nature Human Behavior and in the Journal of Cognition. The situation that we are looking at when we look at rebuttal is the public discussion. So rebuttal was not tested yet in face-to-face private dialogues, for example, patient-doctor interactions. We will look at effective patient-doctor interaction communication guidance after looking at rebuttal. So don't worry, I'm not only focusing on mass communication, we will also look at peer-to-peer communication in a few minutes. But first, rebuttal. What is the problem if we enter a public debate with a science denier or a vaccine denier? The problem is that in this case, Mr. Miller, the vaccine denier, can say whatever he or she wants, because vaccine deniers don't really back up their statements with actual science. They back it up with random statements. And well, the number of random statements is basically infinite. So the difficulty in preparing for such a debate is you never know what the person says in that public discussion. Well, but if we look at what vaccine deniers actually do say, then this isn't an infinite number of statements. The statements actually repeat themselves. For example, Mr. Miller says something like, I will not recommend vaccination until it is 100% safe. If we look at the amount of statements that vaccine deniers produce, then they can all be categorized under 5 core topics. They claim that there is no threat of the disease. They claim that the vaccines are not safe. They claim that there are alternatives to vaccination that are more effective. They claim that you should not trust healthcare workers or health authorities. And they claim that the effectiveness of the vaccines are actually too low to recommend vaccination. So yes, potentially they can say an infinite number of things, but what they do most of the time is they use one of these 5 topics. In this case, I will not recommend vaccination until it is 100% safe. Mr. Miller is addressing safety. So what we could do is we use the 5 topics and prepare a key message for each topic. And then we have a good response that works in many, many cases, because we don't need a key message for public discussions for everything the denier says. We only need a limited set of answers to these 5 topics, and we are well prepared. That is topic rebuttal. We overwhelm the misinformation with facts that actually are true. But there is another strategy that I mentioned earlier, technique rebuttal. We uncover the rhetorical techniques that underlie the statement of the vaccine denier. And by doing that, we inform the public about why that misinformation is wrong. And again, they could use an infinite number of rhetorical techniques, but if you structure them scientifically, then most of the times they just use 5 techniques and repeat doing that. They use selectivity or cherry picking. They just pick out little evidence pieces and claim, well, look at this. I actually told you vaccines don't work and this paper is showing it, and ignore the body of evidence that actually does not confirm their claims and statements. Another example of selectivity is just using a simple narrative from someone you know and say, well, but that specific person actually experienced side effects and they were very heavy, and that may be true, but you ignore the vast amount of people that have never experienced any side effects and are actually protected against a much more severe disease. So selectivity is a very common technique. There is also impossible expectation, and we see that example right here. I will not recommend vaccination until it is 100% safe is an impossible expectation, because no medical product is ever 100% safe. They also use conspiracy theories, claiming that there is a big conspiracy between big pharma governments and independent scientists, and you never know what is true. They use false logic by, for example, stating that because vaccines are not natural, they are bad, which is a false logic, because nothing is bad or good just because it is natural or unnatural. A lion hunting a man in the desert is maybe a natural thing, but it is not good. So this doesn't really work. We also have false experts. They claim that doctor says vaccines don't work, but that doctor has a doctor and a doctor in German language and philosophy, but has no clue about medical expertise or vaccinology. So these are the 5 techniques that are very common in vaccine denial rhetoric and also in science denial rhetoric in general, and they repeat themselves. So rather than preparing for an infinite number of statements that Mr. Miller could say, we can build key responses for these 5 techniques and are good prepared. Let's have a look at a much more realistic example, because vaccine deniers usually don't say just a sentence. They say a lot of stuff. And we see this in this example. The lack of safety is an important issue of the Dysmenorrhea vaccine. By the way, the Dysmenorrhea vaccine doesn't really exist. I just use this because we use fictitious vaccines in our empirical work. The side effects and risks of the vaccine are incalculable. As a patient, you do not know how the body reacts to the vaccine before administration. Even if you feel healthy immediately after the shot, harmful substances may have entered your body. Doctors cannot guarantee in advance that there will not be any complications. In my opinion, you cannot expect any fellow citizen to vaccinate as long as the vaccine is not 100% safe. Surely it is not too much to ask that a product that is injected into a healthy human body is 100% safe. Now, Mr. Smith has the opportunity to identify which topic Mr. Miller actually raised and use his key message that he prepared before the debate, or he identifies the rhetorical technique that Mr. Miller is using and uses his key message that he prepared before the public debate and responds to Mr. Miller. First of all, Mr. Miller starts with the lack of safety. We already know, okay, he's addressing safety. I can use the response that I prepared for safety and have a good message. He also later claims you cannot expect any fellow citizen to vaccinate as long as the vaccine is not 100% safe. Sounds very good, but is an impossible expectation. So what we can also do is not only respond to the safety aspect of that message, but we can also respond by uncovering that this is an impossible expectation because no medical product is ever 100% safe. And that is what Mr. Smith can do from a psychological perspective, from a persuasion perspective in this specific public debate. Mr. Miller demands 100% safety from the vaccine against dysmenorrhea. In science, this argument is called impossible expectation. It is an impossible expectation because science can never guarantee 100% safety for any medical product, neither for aspirin nor for heart surgery. Any treatment poses a residual risk of complications for patients either during or after treatment. So this is technique rebuttal. Mr. Smith uncovers the rhetorical technique. He names it, explicitly says what is wrong about that. And by doing that, he counters Mr. Miller. What he can also do is use topic rebuttal. The scientific evidence is clear. The vaccine against dysmenorrhea is a safe way to avoid the disease. The risk of dysmenorrhea by far exceeds the risk of vaccination. And please let me add the following regarding the safety of the vaccine. We follow a very strict protocol to ensure the high quality of vaccines in the United States. This is also demonstrated by the fact that every batch of the vaccine against dysmenorrhea is constantly monitored, and so on. You get the idea. So what he is doing now is he counters the misinformation from Mr. Miller by overwhelming the misinformation with actual facts about safety. What he could also do in this situation is combine the both approaches. And you could just read the impossible expectation response and the topic response and have a much longer and more sophisticated response. When we look at the theoretical background of that, then there is good evidence to believe that this should actually work. In persuasion psychology, we usually focus on what are characteristics of the audience, the receiver, that make a message less or more persuasive. We also look at what makes a sender more persuasive, and we look at message features. What aspects of a message make a message more persuasive or less persuasive. In this specific case, the topic rebuttal and the technique rebuttal are called refutational messaging because we refute the opposing position by attacking its plausibility and explain why it is wrong. Topic rebuttal is, in psychology, non-refutational messaging. We overwhelm the opposing position by supporting only your own point of view or the facts. Why should a combination work better than single approaches? Well, it is longer and thus more persuasive for people who don't really look at details. They just look, that's quite a sophisticated response, but also it addresses both aspects, the refutational and the non-refutational, and may thus be perceived as a stronger argument. So we conducted empirical work to look whether technique rebuttal, what I just described to you, and topic rebuttal, and the combination of both actually works in mitigating the impact of vaccine deniers in experiments. In these experiments, people received fictional scenarios. In the scenarios, there was information about a disease, a transmission route, severity of the disease, and an availability of a vaccination and a recommendation from, in this case, the German NITEC. Then people rated their attitude towards vaccination and their intent to get vaccinated. After that, they saw a debate. Either they only received a statement from a denier, Mr. Miller, the lack of safety is an important issue of the dysmenorrhea vaccine, we just read that, so misinformation. Another group received technique rebuttal, so there was Steve Miller spreading his misinformation, and then there was another person, an advocate for science, who actually used technique rebuttal, uncovered the impossible expectation. Another experimental group saw the topic rebuttal, so a response to the safety. And a fourth group received a combination as a response. After that, people again indicated their attitude towards vaccination and their vaccination intention. And what we see here is the result of that experiment. On the y-axis, we see the change in intention because we measured intention before the material and afterwards. We can see what the material actually did with the intention to vaccinate. And what we see here are the four groups that I just mentioned. Only the denier, so just misinformation, a response that is based on topic rebuttal, overwhelming the misinformation with your own information, technique rebuttal, which means uncovering the misinformation, and the combination of both approaches. And what we see here is that in all of these conditions, reading or listening, because we did more than one experiment, there was also a mode of listening, reduces the intention to get vaccinated. Listening to that misinformation was actually persuasive. But in the topic rebuttal condition, the technique rebuttal condition, and the combination, the bars are not as far in the negative as in the only denier condition. And that means we have a protective effect when someone responds. That means when you have the opportunity in public discussions to respond to misinformation, do it. You can use topic rebuttal, that means overwhelm with facts. You can use technique rebuttal, that means uncover rhetorical techniques, or you can use the most sophisticated way, a combination of both approaches. All of these approaches are actually significantly different to the misinformation condition. That means they work. Now, the combination isn't that much better. When we look at all the experiments that we did, then again, we find that technique rebuttal, uncovering rhetorical techniques, actually reduces the influence of the denier. Also topic rebuttal. So it isn't just that one experiment. Across all the experiments, here 6, but now we have done like over 12 and it's always the same pattern. We see that rebuttal works. If we look at the combination on the right side here, then the combination isn't that much better than single approaches. What does that mean? If you are good at overwhelming misinformation with facts because you are a medical doctor and you have good knowledge about safety, effectiveness, and so on, go out and do it. Overwhelming the misinformation works, and you don't have to also uncover rhetorical techniques because the additional benefit is so small that it's not worth the effort. If you are good at uncovering techniques because you are media trained, because you have a background in philosophy, because you're just good at spotting flaws in rhetoric, do that, it works. And you don't have to learn all the vaccination information because uncovering those rhetorical techniques works just as well. And the combination isn't that much better. If you're good at technique rebuttal, go out and do it. If you're good at topic rebuttal, go out and do it. Now, in the WHO document, we provide what we call an algorithm of examples of how to do this approach. First, there is step one, identify the technique of a statement. Is it a conspiracy? Is it fake experts? Is it selectivity? Is it impossible expectations? Or is it misrepresentation and false logic? If you know it, you can use your key response that you prepared beforehand. Then identify the topic. Is he talking about, or she, about threat of disease, trust, alternatives, effectiveness, or safety? If you know that, use your key message. And what we also see in the WHO document is the combination of both approaches. In step 3, respond with a key message. But as I said before, it is enough if you are good at one of these approaches and you use it. Let's just have a look at one specific example again that we have used before. And this just gives you an idea of how to use the algorithm and follow the arrows. If someone says, I'm not against vaccination, but I will not recommend it to anyone until it is 100% safe, you know, wait a minute, 100% safe, you can't expect that. That's an impossible expectation. If that person then says, how can I vaccinate my daughter if her safety cannot be guaranteed? You know, well, that is safety. The word itself is mentioned in the message. And then you can look at the actual response example. Expecting 100% safety is impossible. No medical product or intervention from aspirin to heart surgery can ever be guaranteed 100% safe. What we do know for sure is that the risks of these vaccine-preventable diseases far outweigh those of vaccines. In the worst of cases, these diseases kill. So what we have here is not only examples of how you could respond to key messages from vaccine deniers in public debates, for example, on social media or in a bar. But we also know, looking at our empirical evaluations, that this does work. It is an evidence-based approach that you can use and you can train students with to make them active on social media, to make them active in public debates wherever we need a new agenda called scientific facts rather than fake news. Debunking. So what we looked at was the situation in a public discussion when you have the chance to immediately respond to misinformation, for example, on social media. Another situation is when health authorities or medical doctors or institutions need to provide factual information on web pages, in flyers, on posters, in vaccination campaigns. That is where the misinformation is not present because there is no denier saying something and then we respond to it. We ourselves are designing the information. So we can decide which information is present and which is not. Debunking means to correct misinformation that we fear is circulating out there. For example, misinformation like mRNA vaccines actually change the human genome. That's a misinformation, and we can decide now to provide factual information on web pages or write flyers for our practices or use posters where this is debunked. Back in the days, we feared backfire effects when doing debunking. And there were quite a few psychological papers that provided evidence for such backfire effects. For example, Skernick et al. Found a familiarity backfire effect. That means by debunking misinformation, you actually increase the belief in the misinformation. How can that work? Well, the example for the familiarity backfire effect in the specific experiment is when people were asked immediately after reading the flyer that debunked the misinformation, people successfully identified the myth. Okay. However, when queried 30 minutes after reading the flyer, some people actually scored worse after reading the flyer. The debunking reinforced the misinformation. In that specific experiment, Skrönig et al. Provided a debunking about the influenza vaccine and how the influenza vaccine can cause influenza, which is not true. The debunking made that very clear. And then 30 minutes later, people were asked again whether that vaccine can cause influenza. And some people scored worse. The idea is that people forget background information. And one of those background informations is whether something is correct or incorrect. So by saying something like the influenza vaccine causes influenza, people only remember in the end influenza vaccine and influenza and nothing else. The little word not or it is false is forgotten after a few minutes. And so the debunking reinforces the misinformation. That's the idea of familiarity backfire effect. There was also evidence about worldview backfire effects, that people who don't want to believe that, because there are vaccine deniers, start to even believe more in vaccine denier misinformation when reading a debunking, because they start to find even more counter-arguments against official facts. And therefore, it increases their initial position to be against vaccination. There was also evidence about the overkill backfire effect, stating that the more you debunk, the less people believe in the actual facts, because, well, one explanation was there must be something wrong if that person tries so hard to convince me, which sounds kind of ridiculous, but it may make sense if we think about debates and people have so many arguments against something and get really wild about a specific theme that we think there must be something wrong about that. So back in the days, we had some evidence about backfire effects, and we weren't sure whether we could recommend to debunk and how to debunk. But in science, we collect more and more data, and it turns out that most of these backfire effects are not really stable experimental findings. In fact, most of them were not replicated, which means we can't really say when they exist and when they don't. And in most of these replications, debunkings actually worked. And there are now meta-analyses out there that show over and over again that fact-checking, debunking works. It is an effective approach to counter misinformation, and you don't have to fear backfire effects. So if you see something wrong, go out there and debunk. In the old debunking handbook, it stated, ideally avoid mentioning the misinformation altogether while correcting it. And that was because of the familiarity backfire effect. We didn't want people to believe in the misinformation because we corrected it. So people recommended to not mention misinformation at all. But looking at the new data, that is a bit too much. As a precaution, avoid mentioning the myth unnecessarily while correcting it. So you should not repeat misinformation over and over again. That does make sense. But if you repeat it in your debunking by pointing towards the misinformation, then that is totally fine. That means that debunking isn't magic. Anyone can do that. And how you can use the fact sandwich. First, and this is described in more detail in the debunking handbook, write about facts, write what is true. So if, for example, a misinformation is out there, write what is the actual fact. Influenza vaccines protect against influenza and do not cause it. Then warn that a misinformation is coming. Say something like, but people believe in the misinformation that. Then explain where the misinformation is coming from. That is because some people actually experience some feverish symptoms after receiving vaccination, but that's not a problem at all. It's a normal reaction. And then finish your debunking with a fact again. By doing this fact sandwich structure, you avoid most of the backfire effects that we feared back in the days, but you also have a very good format for social media and other media platforms, because you are not putting the focus on the agenda of the misinformation. You look at facts and you embed the misinformation in facts. Also, you provide an explanation. People need and love explanations. Why did they believe in the misinformation beforehand? Why was that the case? If you do not provide an explanation, they start to look for a better explanation of the world. And in most cases, that is just another misinformation. So if you want to erase false information, you have to provide a narrative where that misinformation was coming from and why it is wrong. One of these explanations can actually be technique rebuttal, and you trained that today, meaning provide information about the rhetorical technique that vaccine deniers are using. There are some good examples. This is a German example, video examples on how to do that. The Robert Koch Institute in Germany used these videos to provide debunking in video formats. So that means you don't have to write texts. You can also use good designed videos that provide factual information and explain why misinformation is wrong to educate people. It is also very important in debunking research that you look at who is saying what. In this publication by Pink et al., the information that people should receive COVID-19 vaccines was provided to two different groups. One group received the information that President Biden was saying that. The other group received the information that former President Donald Trump was saying that COVID-19 vaccination is a good idea and you should get it. The participants in that experiments were all Republicans. So when we look at the data, and I just want you to look at the first two red lines, then the researchers compared the effectiveness of that message compared to, so they used the Trump misinformation, the picture of Trump and the text, and compared that to the Biden misinformation, or a neutral control condition. That is the second red line. What you see here is the message was always more effective when Trump was highlighted as the sender. It was not so effective when it was Biden, and it was not so effective if they just received a neutral control condition. So Republicans are more open to information if the sender is also a Republican. And that is a very basic principle. Look for the sender, that you also need to be aware when creating debunking. So pick the correct sender for the right audience. And sometimes it's not the person who knows most or is most educated in a specific area, but maybe just the one who is most trusted in a specific audience. And that person can then deliver the debunking in that way just that I just explained. All right, next step, proactive prevention. So what we can do, rather than following every misinformation and trying to fact check it and respond with complex debunkings and try to make it go away, we can actually protect by inoculate the public against misinformation. That means we help them help themselves by providing them a threat warning that they are the target of disinformation and misinformation, and we provide them with good counter arguments. So what you see here is in a publication that we published in Nature Reviews Psychology, an image of that inoculation procedure. There is a person with a shield, immunity. We call that psychological inoculation. So there is a psychological vaccine, if you want, that can protect people against misinformation. That vaccine on the left side of that picture contains two ingredients. One, there is a warning that you are the target of dis and misinformation. If you know that, you're already in a different state, because now you think, oh, well, the next information that I'm reading could be that misinformation. So people are already alerted, and that makes them less influenced by misinformation. The second ingredient is preemptive refutation. That means you provide good counter arguments against the misinformation. And by doing that, they are not only alerted, but they also know how to respond to the misinformation. So by preemptively exposing people to a weakened version of a counter argument, and by subsequently refuting that argument, attitudinal resistance can be conferred against future persuasion attempts. That is the scientific explanation of what I was saying just a moment ago. We have a threat induction. That means we increase awareness that we are the target of misinformation and disinformation. And we have a refutational preemption, which just means we provide good counter arguments against the mis and disinformation. So just like a vaccination, the interventions based on inoculation theory will activate mental antibodies. That is the idea. We know from research that simple forewarnings work a bit like that. They can increase resistance to misinformation, but there are just more sophisticated ways of doing that. The team around Sander van der Linden from the University of Cambridge was publishing a row of, well, inoculation games that can protect against misinformation by making use of the inoculation theory. Some of them are available online, and you can play them freely in different languages. For example, Go Viral, which protects you against misinformation around COVID-19. And you can also share that app or game with other people, medical experts, but also lay people, and they can play it and be less influenced by misinformation because they are now vaccinated against misinformation. And the empirical data actually shows that it works. What we see here on the y-axis is pre-post difference, fake news manipulativeness ratings. So people rated whether something they saw was more manipulative or not. And what you see is the yellow group, the Go Viral group, identified the fake news as more manipulative than the other groups. They spotted the fake news and knew that this is manipulative, while the other groups, a control group and an infographic group, were not as good. And we also see in later publication that this protects against misinformation also on other measures like intention to get vaccinated or attitudes towards vaccination. So yes, inoculation works, and there are freely available tools that you can use and spread that help you be protected against misinformation. Now, this is a German publication. What you see here, or what I want you to highlight, is that apps and browser games will not work for everyone. This is a media survey that shows that people who are above the age of 50 or even older, above the age of 70, do not really play online. And you can't make them play Go Viral. What they want is information on radio or on newspaper articles, text-based information. That's what they look at. They don't play browser games. And there are a row of publications that show that texts can also work as inoculations. What you see here is, again, the change in intention from the experiments that I showed you at the beginning of the presentation. There were conditions where there was only a misinformation from a denier. And there were conditions where we provided the combination of technique rebuttal and topic rebuttal. And this is the red little light, we also warned people about falsely balanced discussion formats. That means when you have one denier and one advocate for science, then this does not represent the scientific consensus on effectiveness and safety of vaccination. It is a misrepresentation of the entire scientific literature in that one specific public debate. By warning people about that, you could actually reduce the impact of the science denier. That is what you can see in the white bars, because there are lower not as much influenced by the misinformation compared to the darker bars. So in the conditions where a pre-warning was present, the influence of the denier was reduced. And that pre-warning was just basic text. Basic text like this one. In another publication, we showed that in the elderly population in Canada, a simple text-based information that they are target of misinformation and what the techniques are to mislead them can actually reduce the influence of social media misinformation for that population. The key message here is inoculation works, and you don't always have to use apps or games. You can also build your own inoculation interventions by just writing very good texts that warn people and show which kind of techniques are used on them to mislead them in specific directions. Now, we talked about debunking and pre-bunking, and sometimes we are in that situation where we think, so when to use what? If you have a misinformation, and that misinformation is expected to circulate a lot because you know from previous pandemics, or you know from information from vaccine deniers that they used for MMR 10 years back, that this myth will also be circulated during the next introduction of a vaccine and so on. Use pre-bunking. Inoculate people before that misinformation is entering the stage. That is the best chance we have, because then they can help themselves and we don't need to debunk every single myth that is coming along. If the misinformation is already out there, it may be too late to inoculate. Then we have to ask ourselves, is the visibility of the misinformation a problem? Is the myth largely unknown? If it is, well, keep monitoring, withhold debunking, but be prepared that it may be necessary. If the myth has traction, you can use the debunking approach that I just explained using the fact sandwich. This decision tree is very simple, but it helps in some specific situations to decide which of these strategies is actually necessary. And it is described in way more detail in the debunking handbook that you can look up afterwards. So a last step that I want to show you before I finish, because I'm looking at the watch. Yes, right in time. The last step is about peer-to-peer communication. That means not mass communication. Most medical doctors are not only involved in mass communication in their own community or on social media or in specific roles as advocates for science. Most of them are involved in peer-to-peer communication. That means face-to-face in private or a patient-doctor interaction. In those situations, the most promising approach that we have for now is motivational interviewing. The goal of motivational interviewing is to strengthen the relationship and show empathy and interest towards your discussion partner. The question that is used for motivational interviewing, the key question is, what is the actual reality of the individual that I am talking to? So rather than just providing facts or telling people, no, you are wrong because you used this and this rhetorical technique, the goal in peer-to-peer communication, in direct dialogues, is not first to say that someone is wrong, but to understand the reality of that person. So rather than starting a discussion with something like, it is important that you vaccinate your child, did you know people die from it, and the other side effects, we need to step back as experts. We should not do that. We should not open all doors and say everything we know, intimidate the patient, and give him or her no room at all to express fears. What we need are open questions. That is the first step of motivational interviewing, reflective listening, and affirmation. What does that mean? First, we should ask something like, what do you think of the benefits of vaccination? Only by asking open questions, the patient or our dialogue partner can open up and actually express what they think and what they fear. If we ignore that and just provide facts, we will never know whether we actually addressed the concerns the patient had. So in this example, what do you think of the benefits of vaccination? Well, vaccinations may protect, but I'm concerned that something will happen. This one study by, and so on and so on. The next step is reflective listening. So you recognize the benefits of vaccination, but only if they are sufficiently safe. What the doctor is doing here is just repeating the key message and interpreting what the patient was saying, reflective listening. By doing that, we repeat what the patient was saying and we avoid misunderstandings. At that stage, the patient could say, well, no, that's actually not what I was saying. I meant something else. The other aspect of that is sometimes when we hear what we said from another person, we realize, oh, well, no, actually, no, that's not what I meant. I was trying to say something else. So this is a phase of where we try to find common ground. Are you saying this? Are you saying that? Reflective listening. The next step is affirmation. I see you have informed yourself a lot. You are right. Affirmation is very, very difficult for experts. When someone is telling misinformation to me about psychological evidence, then I am in that position to say, no, you're wrong. Here is a paper, read it, you're wrong. But actually to affirm the position of that other person and saying something like, where did you read that? Well, I just read it online. Oh, yeah. If I would read that online and I have only received that kind of information, I would probably believe the same thing. But can I give you like some insights from my experience as a psychologist from the 10 years I was working in that field? And if you offer that expertise, it is much better than override the person with your expertise. Make information an offer and not just the default in those specific discussions. So the 3 ingredients for motivational interviewing are open questions, reflective listening, and affirmation, and not just facts. And there are actually some empirical evaluations of that approach, and it works in the vaccination domain very effectively. Here is a longer example of that, but you can read that in Garneur's publication, Motivational Interviewing, a powerful tool. Here, it is also the same thing. That person here, the healthcare worker, is just starting with facts, and the mother doesn't really know what to say and is just put into one corner. While when we look at the motivational interviewing approach, it is much more open and much more patient-centered. We have another practice, but I have to skip that looking at the time. What I wanted to do with you is a little exercise where one of you is playing the healthcare worker and one of you is playing the patient, but that will cost way too much time. But this is something you can do as a trainer using these slides. If people look at those 2 different texts, the traditional one, what you shouldn't do, and the motivational interviewing one, what you should do, they can play along doing exactly that in role plays. And by experience, this actually helps to learn the 3 steps by heart, meaning that you actually ask open questions, that you are reflective, and that you affirm the position of the other person. One last thing before the end of my presentation, sometimes people, when they use motivational interviewing or other aspects, they end up doing the right thing. They ask open questions, they provide an environment that is respectful, and then they don't really know what the facts are they should communicate. When we look at psychological evidence on good content that we can use in communication, then we have 3 key messages. We should communicate the scientific consensus on vaccination, but also on other issues like climate change, because it does work and it increases the support for vaccination in participants. Statements like 90% of medical professionals agree vaccines are safe is influential. Also saying that most of the doctors actually would get vaccinated themselves helps people to make a decision. It is also very important to explicitly say that you as a doctor recommend the vaccine. Sometimes doctors just imply that this is clear from the beginning. They should explicitly say that. And it is also very good to communicate community protection or herd immunity to the public, because that social aspect of vaccination increases the intention to get vaccinated in most experiments. There's also a way of being emotional. So sometimes it is not enough to just focus on a specific person. And we saw in empirical evaluation during the pandemic that for mask wearing in younger populations, it is actually very important to raise concerns about how risk groups like elderly feel when they can't visit their wife because it is lockdown, when they can't go outside and meet the people they love during the last years of their life. And this additional empathetic information can also increase the intention to get vaccinated and make people aware that this is not only about them. There was a publication 3 weeks ago, and that publication actually supports what I was just saying about the scientific consensus. This was published in Nature. Communicating doctors' consensus persistently increases COVID-19 vaccinations. And it is a beautiful publication because it shows on the actual uptake level that just providing information about the scientific consensus on vaccination increases vaccine uptake in that specific group by 4%. It is an intervention that is very cost-effective because just providing the information about scientific consensus doesn't really cost a lot, but it increases in that specific publication the vaccine uptake rate by 4% over a long period of time, which is very impressive. So simple messages can actually make a change. We also highlight everything that I just said in a new publication by Nature Reviews Psychology, the psychological drivers of misinformation belief and its resistance to correction, that is also provided as a resource in the background document that you will receive as a participant. So I hope that the insights in these 3 documents help you. I know they are not a solution to all the misinformation issues we have. We are still working on many, many more approaches for different situations, but I think they are a good resource to actually look up specific issues and help you become better communicators. I'm working in a project that is actually specifically looking at countering misinformation, and you can follow us on our webpage, jitsuvax.github.io, and we are specifically working on improving guidance for medical doctors on how to respond to misinformation during patient-doctor interventions. And we are working on a homepage right now where you can basically enter the misinformation your patient said, and you receive through AI a direct response what you should say in that specific situation based on the best psychological knowledge that we have at the moment. So keep yourself up to date watching that web page, and I'm sure I will use all of my other communication tools and channels to just provide you with that specific information once that website is up to date. Thank you so much for listening, and thank you so much for participating in our little exercises.
Thank you. Thank you, Philip, for your very interesting and very concrete talk. I think we all learned a lot, and we are really inspired about how to train healthcare providers on this topic of communication about vaccination. We have now already arrived at the final part of this training, and for this final part we would like to welcome Willie Georgi. He's a pharmacist from Berlin, Germany. He studied pharmacy in Jena from 2014 to 2019, and during his studies he became active in the National and International Pharmacy Students Associations, BPHD and EPSA. In 2018 he graduated from a Training New Trainers event, and he has been active as a soft skill trainer, mostly for pharmaceutical and medical students in Europe. In 2021, he was training professionals as a part of the CTIS Master Trainers program of EMA, and he is currently working for the German startup Blue Health Group. His tips and tricks will be valuable for when you will be setting up a training based on this Train the Trainer session. So welcome, Willie Georgi.
Well, thank you, first of all, for having me here. So good afternoon, everyone. After the parts that we had, I will provide you the last input, which we're going more a bit more off topic from the vaccinations and going more into the methodology and thinking about how we can actually train and teach other healthcare professionals and what to keep in mind for doing so. So for this purpose, I've selected three particular theories to keep in mind when designing a training course or a workshop for other healthcare professionals and teaching them about, for example, vaccine hesitancy. So the first one is to set learning goals. When we think about teaching and training a specific content, especially if we have a lot of content, then first we need to keep in mind where do we actually want to go and where do we want our participants to go on the proficiency level when the session has ended, when the training is done, when the workshop is over, and what should they be able to do. And this also concludes with the amount of time that we can get. So here for what you see is Bloom's taxonomy. It was devised by Mr. Bloom, Professor Bloom, in the last century. He was an educating theorist, and he put together, based on his knowledge and his experience, these kinds of levels of understanding in a certain skill, in a certain field of knowledge, where we can go. And when we train new healthcare workers in a specific situation, for example, communicating about vaccine hesitancy, then we can focus on the bottom three that we have here, on the level of knowing, of understanding, and of applying a certain thing. So these levels, they actually build up on each other, with knowing the most basic one, and mostly universally already there. For example, we know that vaccine hesitancy exists, and we can probably see certain routines happening or certain expressions being made by patients, and seeing that this is a sign of vaccine hesitancy, but we do not necessarily understand where does it come from, how we can characterize it. Therefore, we need deeper knowledge. So if we want to teach it, then first we need to set the ground rules, see that we are all on the common knowledge level, and then we can go on to the deeper understanding, which is actually what happened before, just in the last presentation that we had, where we first got to know about the vaccine hesitancy, and then we went into deeper understanding of how we can characterize it, the different parts of rebuttal that we saw, like the 10 different ways or the 10 different categories that we can drive it in. And then the next step is when we understand and can differentiate each one of them, then we can actually go to applying and going out into the real world and trying to let our participants apply this. So when teaching our co-workers, other healthcare professionals or students about a certain topic, then this is the way to go. First on the knowledge level, then giving a deeper understanding and making them able to understand, to explain, and then to apply. And there we can set the learning goals, which can be easily done with the certain verbs that we have put here. For example, if we want to go to the comprehension level, when we have a 1-hour training session on the topic, then it is very proficient to go to the comprehension level. And there we can set our goal of being able to characterize different ways of vaccine hesitancy, or describe why vaccine hesitancy is happening. While when we want to go to the application level, where we need to have more time, then I can set a learning goal of my participants will be able to implement at least one communication technique in a discussion with a vaccine hesitant person, or is able to execute this specific theory. So this keeping in mind where we want to go, and this combining with the time that we have to be able to set a reasonable learning goal and then choose the content according to the learning goal. So then the second one is to have a structured session, actually. Here we have a 4-step model which is called format because of the 4 quadrants that we have. And it is essentially a model that helps you to engage as many different learning types and as many different individuals as you can within your session. And this you can do by just answering the 4 questions within your session, ideally in a fixed order, but the most important part is to actually answer these questions to get as many people in as possible. When we think about teaching individuals, then especially adults, they come with a certain expectation and they come with a certain background. And this is different from when we were teaching kids or when we were taught ourselves in school. Then mostly what was happening is that we were just like this sponge that was ready for new knowledge, and the teacher had a devised curriculum and we were just taking it in as it was coming. With adults, we actually need to answer a few questions for them to be able to go out into the world and really apply the knowledge and apply a new skill that we want to teach them. Because this is different than just teaching a theory. We want them to be able to execute. And in order to do that, we can answer the 4 questions. The first one is the question of why. Why are we learning this? Why are we talking about this? And why maybe we're choosing a specific approach today in our session? Why did we choose a certain theory? This is all coming down to the part of engaging our participants, the adults that we have in front of us, and connecting it to their experience, connecting it to their background from where they are coming, and bringing them into our session. So answering the why of what we are doing here. This, for some people, might be very obvious, but it helps, especially when we have a bigger group of people, maybe 20 different ones, or even like in this setting, we have over 50 people here. Talking about the why we are doing this is important to go on the same starting point and then going out and applying. So the next question is, of course, what are we talking about? And what is the theory that we want to share? So in this case, in the what, we're presenting our facts, we're presenting our theory, we're presenting the approach, maybe also giving a bit of background, but giving the theory input to our participants so that they are able to see and understand what we have. The next step then is to practice it. This is especially important when we want to teach skills and when we want to teach a very practical something that needs to be practiced in real life. So after we share what is the theory, we go on, okay, how can we actually implement this? And here we give a scenario, maybe a role play or a case study, and we actually apply the knowledge, which is, we did that before in the last presentation as well. First, we had the theory on the different definitions on how we can categorize the vaccine hesitancy. And then afterwards, we had a question, we had a sentence, and then we needed to be able to identify which one it was. So we interacted on another level with the theory, so we practiced it. And this can have different applications depending on which learning level we want to go. For some, it can be understanding and just recognizing, being able to categorize. If we want to actually practice applying the theory and actually practicing the talk, then we can also do role plays, giving situations, do demonstrations with our participants, and just helping them to practice and interact with the theory, especially in a safe environment, let's say. And the last one is the question of if or what if. This is the point of the session where we go and open our horizon and think about what happens after the session. So we had a theory, we practiced it in a very safe environment. We're all, let's say, on the same page on where we want to go, but now we go out into the world and we need to practice it in real life. So what can be scenarios that can happen, which we might need to be prepared for? How can I ensure that I remember the things that I learned within the session? This is essentially to make sure that our participants don't forget about our session 2 hours after it was done or 2 days after it was done, because what we want to do with those newly learned skills is we want them actually to apply them in the real life contents. So here we try to make to give them a sense of reliability or accountability to themselves, that they will be using what we have learned in the session. There's among us, there's people who prefer to learn or who need to at least one of the questions answered. And if we omit one of the questions, it actually omits a part of our participants. And answering all 4 of those questions within our session will give us the ability to get as many different people into our session as we want. So, and then the last one is to engage our audience. If we want to have a session where we want to teach a new skill, then it is important to switch up how we are teaching it. So we cannot just do a presentation, because it's just a presentation for 3 hours in a row will at the end, they will have heard about the skill, they will have listened to it, they will watch our presentation on it, but they will not be able to actually apply it. And what happens if we just hear a presentation throughout 3 hours, then our attention span, it slowly decreases, and what happens at the end, we will not be able to notice. So we can involve our participants and actually make them interact and giving the input that we want in the session. We don't need to be the one who all the time needs to give all the input. If we maybe go back for a moment, here in the sharing part, it's most commonly that we are the presenter, we are the expert in giving the theory. But then when we move to the practice part and we give them a role play that they can act out within a group, or we give them a case study that they need to solve, maybe with groups of 2 or groups of 3, then we don't need to be the one hand holding them in all of the process. They can interact with the theory, they can see how they can apply it, and in that moment, they will be giving the contribution to the content. So what you see here is the so-called facility training rainbow, referred to by some trainers, and it shows different methodologies that you can use throughout a workshop or a training session. And they are ranked by 2 things. First of all, the contribution from the facilitator to the content, either as low or as high. And the second one is the interaction with the participants, which is also low or high. If we take the presentation, for example, in a presentation, me as the presenter, I'm giving all the content right now, and we are not interacting. So it's a very high contribution to content and a very low interactive level. On the other side of the spectrum, we could have a process monitoring. If I give you a case study to do and put you in groups and give you the task, tell you 10 minutes, here you go, then I will be there for the 10 minutes, watch everyone else doing the process, but I will not really contribute anything to the content, and I will not really interact with my participants. So there will be a different dynamic within the room. And then we can also use other methodologies which increase the interaction level with the participants, where we also get our participants in, especially when we have, again, adults in our session who have previous experience, who have knowledge prior to the session, which is most of the participants, or most of us, we don't think when we go into a new course that we cannot contribute and we just want to listen to what the expert has to say. But if we want to practice a new skill and to learn a new skill, then most often, if it's in our profession or an extension of our profession, then we already have experience that we can share, and it can help the group to learn something new and to go along and help with the teaching process. So if we involve our participants, for example, in a brainstorming or in a discussion on a certain question on how to best approach it, or how to best utilize a certain skill or a certain theory, then we can bring them in. The energy level also increases because our participants are not just sitting in front of the computer, just listening and trying not to fall asleep, but they're actively thinking on what is happening. They're giving their input. They're bringing it in. They're bringing themselves in. So this will increase the dynamic and the energy level within. And then, of course, what we have on the other side, teaching and demonstrating, is what we know from school mostly. When we want to practice something, then it's good to first demonstrate, maybe with a few participants, or if it's a practice where we have a specific example and a specific way on how to deal with a situation, then we can actively help and maybe do a role play. And we, as the trainer, as the expert, we interfere a bit and give some nudges in the right direction. So we help and teach along the role play that is happening. And on top, we have the Socratic direction, which we can also refer to as coaching, where we give the direction to our participants towards a certain learning goal or a certain conclusion that they should have. But we do not tell them upfront. We ask them questions which bring them to this conclusion. The Socratic direction is one of the most powerful learning techniques that we can have, because it involves active thinking on both sides, on the participants and on the trainer, and the trainer leading with questions and bringing the participants' thinking process and thought process to a certain conclusion, which will stick more in the end than if we just have told them, like, this is the way how to deal with a situation. If they actively make their heads and their brains work and come to the conclusion themselves, it will make more sense to them and it will stick on a much deeper level than if we just tell them. So with that, that's the 3 tips and tricks that we can provide from our background. These 3 models are actually what we use in the student community and the soft skill trainer community that we have within students. A few of the European student associations such as EPSA, EMSA, ELSA, they have student trainers which use these methodologies to design workshops and teaching soft skills to other students alongside the university curriculum. And it is what we have seen working and that has submitted in practice. So if you want to apply some of these, I can just highly encourage you to think about the people that you have in mind and to actively shape the training for your participants that you're going to have. So with that, thank you. And yeah, I'm looking forward to the Q&A.
Okay, thank you, Max, for these insights, which are very valuable for setting up a training. Now we still have a bit of time for Q&A, so please feel free to ask any questions you might have for our speakers. If you want to ask a question, you can virtually raise your hand and we will give the word to you, or you can post your question in the chat and we will follow up. So let's go ahead with the Q&A and you can ask your questions now.
There we go. Yes, already Pierre here. What I would like to ask, in fact, to the audience, but I can ask it to Brett, but also to the other presenters. From the point of view of healthcare providers, in particular, I would say in the COVID-19 situation, but also in general, there are a number of challenges, and one of these challenges is the time they can devote to find information, and we make a lot of information available on websites through Q&A. We have seen the example of ECDC, the example of WHO Euro, But at the end, when they have a patient in front of them, they have no time to look for that information. By the evening, they have to do a lot of administrative work. Have been complaining in Belgium about a lot of administrative work as well during the COVID period. So I fully realize that this is not evident at all. And I think what we should perhaps also try to offer to the professional organizations is exactly what is already available on the websites, but that they can do a kind of translational effort according to the language, but also according to what is really needed in a region, in a country, because some, I would say, fake news is circulating in one part of the country, but not in the other part of the country. So really to tailor the information that is available on your websites, but to tailor that to their GPs, to their pharmacists, and so on. So I see an additional role, I would say, for the professional organizations to play a kind of translational duty to assist, to help, taking into consideration language issues, but in particular also time issues at the level of the frontliners. What do you think?
Thanks, Pierre. That's an excellent point and idea, and I couldn't agree more. And I think, as you mentioned, that really is best done at a local level in order to, filter through the amount of information and find out what is most pressing. And it has changed throughout the course of the vaccine rollout as well, which are the pieces of misinformation, which are the safety concerns. And they can vary by age group also and by different population groups. But one key way is to try to simplify. And we've had some countries actually do that, where they went through our website and they talked with some of our vaccine safety experts and then tried to narrow it down, like the top 10 frequently asked questions, translated that into local language and put it together as sort of a brochure for health workers. Again, as you mentioned, because of time, to be able to just say, I see you have lots of questions and I can't answer all of them right now, but here's some information for you that'll directly address those questions. And I'd like to also add one other idea that came out of in Kyrgyzstan, where we worked with them on identifying those common concerns among patients and then did a communication training with their healthcare professionals. They had the idea of piloting in their primary healthcare centers. They have a sort of counseling resource, and typically it's used for lifestyle changes, diet, alcohol, tobacco, etc. But they said, this is an opportunity for us. Why don't we add vaccine information and vaccination counseling to this vaccination center and see how that goes, so that those who have more additional concerns and questions could actually be directed to this counseling room right there in the primary healthcare facility. And then some more time could be dedicated to answering questions than, for example, the GP might have in that short amount of time. So I think it's a great idea that we want some flexibility or some innovation to happen at the local level to see what might work best with the existing resources, but definitely simplifying, or I should say narrowing down to the most pressing common concerns around the vaccines at a local level is a great strategy. And the translation is also key, because with so much information, we've always been behind with COVID-19 vaccines, especially. It keeps changing, and getting it not only available, but available in so many different languages in the countries has been a challenge that we hope to be able to catch up with as well. So hope that addresses your topic, but
thank you.
Point.
Thank you.
Okay, I see we have another question in the chat from Maya. I think this might be a question for Philip. What would be the best technique to teach healthcare workers to respond to disinformation spread by other healthcare workers?
Yes, thank you very much for that question. I mean, that is a very specific situation where you have other medical experts, so there are not fake experts, spreading mis and disinformation. And this is a very crucial situation in which we need to use fact checks, and in which we need to debunk that specific misinformation and not rely on mere authority. Because in that specific situation, it's a draw, right? You cannot say I'm a doctor and then the other person says, yeah, well, I'm a doctor too. So now in that specific situation, expertise, the sender itself, it does not play a big role anymore. So it is about the content that we spread. And in that specific situation, I would say the content about uncovering rhetorical techniques, providing links to actual evidence is more important than ever. Because now it is all about the specific argument strength and not about the reputation or the authority of the sender. And that makes it even more important to look at your specific arguments. And it is very important to counter even other so-called experts if they are making a false claim. Sometimes we need to identify whether that claim is actually because it is a denier, or maybe that person just misunderstood a paper. It can also be the case that a medical expert is not a denier spreading false information, but he's actually convinced because he saw a specific figure that this is the case. And so it is our responsibility to correct, and not from a position of I know better than you, or you are a science denier, but in a way of trying to stop the spread of misinformation and being respectful no matter what. There are papers out there that some of these labels like fake news or science deniers are increasingly used as a strategy to silence people, and that's not what they should be used for. These are just scientific terms that you can analyze. But when it comes down to the debate, you shouldn't just call someone a name, but look at the arguments and use a good argument. Whether he is a doctor or whether he's just an ordinary person doesn't really matter. Try to fact check and try to be respectful.
Okay, thank you. Another question for you, Philip, is how should we use storytelling in a positive and meaningful way in the conversation with vaccine-hesitant patients or parents, or deniers?
Yeah, I mean, there are several ways of how you could read that question and also how you can answer it. Storytelling can be used to also create a draw. Again, if a denier or a hesitant patient is using selectivity, storytelling him or herself as evidence, something like, I know someone who has experienced X, Y, Z, then we can also use storytelling by telling that person, well, I know a patient who actually died of that disease, and then we have a draw. So if we both know specific examples of what can go wrong, let's look at the scientific evidence, because every single data point tells its own little story. And then we can come back to the actual evidence, make a draw with storytelling. That's possible. That's one way of using it. The other way of using storytelling is to just use it as a way to make data more understandable. And I highly encourage you to do that, but because many people are not used to reading graphs or meta-analysis and so on. So it needs a story to make that understandable to people. And in those specific situations, it can be very helpful. And I have to say that does not mean that you should avoid numbers. Sometimes people think when using storytelling or when trying to make something very simple that they should not talk about numbers. There is actually evidence out there that if you just use plain words rather than the correct numbers, that people over and underestimate the risks because they don't know what you're talking about. So use numbers, but use storytelling to make them more appealing.
Okay, thank you. I see in the chat that there is, I think it's more a comment than a question. Time is always issue. Engaging other members of the healthcare team to relay consistent key messages. So I think that's mainly a comment stressing the importance of being able to engage other members of a healthcare team. Are there still questions? Don't hesitate to put them in the chat, or maybe just raise your hand and then you can ask your questions via microphone.
I would like to ask a question to Max. If you start your triangle with the knowledge at the end of your step in of your course. If you are now training healthcare providers, can you skip this step of knowledge? Do you think that it's a good idea to skip this step and immediately go to the next step, taking into the consideration that you are here working with healthcare providers that should have the knowledge? Is that the way to go, or do you think you always have to first go for the knowledge step?
I think it depends. Like with the healthcare providers that we have, the knowledge step is there. Like we know what vaccine hesitancy is. It doesn't hurt to just take 5 minutes to set the basis on what we are talking about, and also in which frame we are talking about. That can be difficult if we think that we talk about different things. For example, if it's just about the COVID-19 vaccines, or if it is about vaccines in general. So then we can quickly move on to the next one, and then go focus on the understanding and then the applying. That would be our advice.
Thank you. Sorry, Philip, I still have one question for you also. It's when you are doing surveys on vaccine hesitancy and vaccine confidence, a lot of times people say that they trust most their healthcare provider and that they would ask their questions to the healthcare provider, but I'm not always sure that the people really ask their question to the healthcare provider. So my question is, would you say to the healthcare providers, when you have talk with your patient, go proactively speak about vaccines, or do you think you better wait until that they ask their questions that maybe never comes? So it's more to see how we can, this preventive way of talking about vaccines, how can we do that?
Yes, excellent question. I mean, often it's an issue of time limitations for medical doctors. I know they have little time per patient, so it's very difficult to do that every time. But being proactive is key here. The motivational interviewing idea is that you actively ask the open question about vaccination, because then a dialogue is generated in which you can provide a clear recommendation and also provide the facts. If you wait for the patient to open up the issue, it may never come that day, as you said, because we can all think about that. If we face an expert, we sometimes feel intimidated by their expertise, and we wait for that person to raise specific topics because we think it may be stupid to ask, it may be stupid to raise a question about vaccination. If the doctor is not mentioning it, it may not be important. And all these impressions are within the patient, and he's leaving and going home and will think like, maybe I should have asked that. I don't know. The doctor didn't say anything. So it's really up to the expert to understand that asking questions is difficult, and we should just ask open questions ourselves if we want to raise that issue. And we see in most of the data that recommendation by the medical doctor is the most effective thing we can do. So bringing people into a dialogue where that recommendation can be placed is very important.
Thank you.
Okay, I see that in the chat, Alison is going back to the comment from before, the comment about the importance of engaging a whole team. So Alison says that it's very important to ensure that everyone on the team feels confident to share reliable information about vaccines. So training should ideally reach not just the healthcare providers themselves, but also, for example, supporting administration, admission staff, and so on. So the question here is if someone from our panel knows of any vaccine communication training materials that are reaching this wider audience. So not only healthcare providers, but also this wider audience of the whole team. Is there anyone of the panelists or maybe the public who knows about materials like that?
Oh, sorry, Philip.
Yeah, sorry. I just wanted to say that most of the communication advice from the documents that I presented is of course useful for healthcare workers because they are in the specific situation talking to patients and so on. But these are general findings that are not limited to specific professions. So they can be used by basically anyone. The psychology behind that does not rely on expertise from healthcare. So you can also use that if you are from a specific other profession, if you have admin staff and so on. They all can use debunking, they can all rebut, they can all use motivational interviewing. You can do that if you're a layperson, an expert, and so on. It may be the question whether you need to do that as a layperson, but it will be effective if you do. So all of these guidance documents can also be applied for other professional groups. But I don't know about a specific guidance book that is tailored to, for example, admin staff or something like that. I'm not aware of that.
I wanted to add that in the curriculum that we developed, we also included communication and communication techniques in the curriculum. And we see this as a wide curriculum that could be used for students, for all students, if it's nurses or midwives or what you can think about health care professionals. So talking about communication on vaccination in the education already would be a positive point to do, so that then not only the GP but all other involved people have knowledge at least on on talking about vaccines.
If I could just jump in also, we developed 2 training modules during the COVID-19 vaccine rollout that were specifically about COVID-19 vaccination. And the first was for health workers communicating with patients. So it was very structured in a more of a clinical consultation setting. The other was actually also for health workers, but how to communicate with peers, with colleagues, other health workers. But actually that training is, I think, very applicable to a wider audience in the sense that it's not so much a consultation setting, it's more natural conversations that arise with conversation tips on how to respond, how to ask questions, etc. And I think that would be, and I'm happy to post the link in the chat here, but that also is something that can be used, again, more broadly, that just anyone can learn these skills, as Philip mentioned, that can be very widely applicable. So I'll share that in the chat.
Thank you. We can also put a link in our background document so that we can consult it. Are there other questions? Okay, I think if there are no further questions, we can end our session here. Before we go, I would like to ask you to evaluate this training by filling out the very short evaluation survey that you can find in the chat. Again, it takes less than a minute and it would help us a lot in evaluating this session. So as you know, in a few weeks, the recording of the session will be made available on the website of the Coalition for Vaccination, and the background document that we talked about will be provided with the slides that you have seen today, but also additional materials that could help you when setting up a training. The details of the speakers will also be included in the document so that you can reach out to them if you still have questions. So finally, I want to thank you very much for your presence and your active participation in this session. We really hope it has inspired you to train healthcare providers in your country about this very important topic of communication about vaccination. Thank you very much.